चलो बच्चों, hopefully all of you are fine. Good evening everyone. Hopefully all of you are fine. Hopefully all your preparations are going fine as we are in the last phase of your preparation journey now. All of you have been revising your notes consistently. Now at this point of time, more important is to have faith and belief in yourself. And do remember, whatever you have learned till date is enough to pass the FMG examination. You don't have to search for a lot of new videos or new PDFs. Just keep on revising, okay, your same notes. Here we will be just discussing some important questions where in case you are having an issue to decide the next line or the first line of management. So with these kind of questions, I'm just trying to. So these are few different questions, but they are not the same as I've taken in the previous videos. These are few more questions so that you can actually have a question practice of surgery questions, because a lot of people get stuck in the questions usually, not in the recall. So as you have revised the notes or as you have watched the previous videos, now it is important that you can just go through this video faster so that you can learn that what is the actual type of questions which may appear in the examination. You don't have to feel tensed, because I know that you are going to pass the examination with flying colors. You need to have that belief, you need to have that trust in yourself. Don't worry, the session would be for a shorter duration of time. I'm not going to extend it too long so that you're not going to waste a lot of time basically in just prior to the examination, right? Chalo, great. So let's start without any further delay, okay? First of all, here you are having a question that states, we are having a question number 1 that states, a term neonate was brought to you with complaints of marked abdominal distension beta, and there was no passage of meconium. Okay? So as the child was not able to pass the meconium since birth, that's the reason the child is having a marked or a severe abdominal distension. Okay, on performing DRE or on performing digital rectal examination, the meconium passage was observed. So the baby could pass the meconium once you have done a DRE or digital rectal examination and stimulated the rectum. And contrast enema or varium enema was done, which has been given below. Okay, now they are asking you what is the defect in the given condition. So I hope all of you are quite aware. Hopefully now the question is visible to you. Now the question is visible. A term neonate brought with marked abdominal distension, no passage of meconium since birth. On performing DRE, meconium passage was observed and contrast enema done, has been given below. What is the defect given in this condition? So I hope all of you are quite aware, beta, that whenever, do remember, whenever a patient is having a complaint of meconium ileus, what is meconium ileus? That the baby was not able to pass the meconium or the first stool since birth. We all know that we wait for the baby to pass the meconium for a duration of 48 hours. Understand, we wait for the urine passage up to 24 hours and we wait for the meconium passage up to 48 hours. But even after 48 hours, if the child is not able to pass the meconium, we call it as delayed passage of meconium or no passage of meconium. That is meconium ileus. Now, after a child complains of meconium ileus, the next step is doing a DRE, that is digital rectal examination. And once we do a DRE or digital rectal examination, beta, following that, you can observe two things. One is basically after performing digital rectal examination, okay, the child is able to pass the meconium. If on digital rectal examination, you are able to see passage of meconium or passage of stools, beta, that means it is a classical diagnosis of a condition known as, let me know. Yes, all of you are right. Whenever on performing DRE there is passage of stools or passage of meconium, it is a classical condition known as Hirschsprung's disease, also called as congenital aganglionosis or congenital megacolon, right? So Hirschsprung's disease is known as congenital aganglionosis or congenital megacolon. But on performing DRE also, if there is no passage of stools, then please tell me what is going to be your diagnosis. Even on performing DRE, if the child is not having any passage of stools, beta, then what is going to be your likely diagnosis? Let me know that in the chat box. What is the provisional diagnosis where the child presents with meconium ileus, but even on performing digital rectal examination, beta, is not going to help us to pass the stools? Very good, Edwin. Yes. So the correct answer for that question is going to be cystic fibrosis. Shabash. So we know whenever there is no passage of stool, even on performing DRE, that is a classical diagnosis of cystic fibrosis. Because we know cystic fibrosis or mucoviscidosis, in that condition, the meconium of the baby is so hard that even on performing diary, the child is not able to pass the meconium beta, right? That is due to the hard meconium which is seen in the baby. Very good. That is important to be remembered. But here they have clearly mentioned that on performing digital rectal examination, the baby or the neonate was able to pass the meconium. Okay, so that's the reason we know as passage of stools or passage of meconium was seen, we know it is a classical diagnosis of Hirschsprung's disease beta. Now, in cases of Hirschsprung's disease, do remember we can do a barium enema or a contrast enema. And on that barium enema or contrast enema, can you see this segment of the colon? This segment of the colon which is there, it appears to be collapsed. Why this segment appears to be collapsed? This segment is collapsed beta because there is no motility or there is no peristalsis in this segment of the colon. Why? Because this segment is aganglionic, right? As this segment of colon is not having any ganglionic cells beta, as it is a aganglionic segment, that's the reason basically we can say, as it is an aganglionic segment, therefore the segment appears to be collapsed and therefore the child is not able to pass the meconium beta, right? So that is what is important to be remembered. Now, here they have asked you what is the defect in this given condition. So you have to find what is the defect seen in cases of Hirschsprung's disease beta. Now let's see one by one. Option A says there is failure of migration of neural crest cells in the distal gut. So do remember beta that failure of migration of neural crest cells in the distal gut, that can be a true statement, because yes, when the neural crest cells are not going to migrate in the distal gut is not going to have any kind of ganglionic cells beta. So that is what is important. Option B says defective chloride channels due to the CFTR gene mutation. No, because we all know these defective chloride channels which are there, okay, due to the CFTR gene mutation, that is the cause for cystic fibrosis. So if they would have said that on performing DRE, the meconium was not passed, then I would have said it is a diagnosis of cystic fibrosis, and then my answer would have been option B, where they say defective chloride channels due to CFTR gene mutation. Option C says loss of ganglionic cells in hypogastric nerve plexus. So do remember beta, it is loss of ganglionic cells, that's an absolutely true statement, but it is not seen in the hypogastric nerve plexus beta. That is what is important to be remembered. Okay? It is the loss of ganglionic cells, but it is not usually in the hypogastric nerve plexus beta. Clear? It is in the Meissner's as well as the Myenteric nerve plexus, which is present in the distal part of the colon. So we know in GIT there are two types of nerve plexuses: the submucosal nerve plexus called as Meissner's nerve plexus, and the muscular nerve plexus called as Myenteric or Orbach's nerve plexus. So there is loss of ganglionic cells or absence of ganglionic cells in both the plexuses, the Meissner's plexus also as well as the Myenteric or Orbach's plexus also beta. It is not about the hypogastric nerve plexus. Clear? Hypogastric nerve plexus, yes, it usually innervates the rectum and the upper part of the anal canal beta. Clear? That is important. Option D says atresia in the distal segment of bowel. No, atresia means no development. Here the bowel is developed. Here the bowel is completely developed. So there is no problem of atresia basically. The problem is absence of ganglionic cells. So the answer to that question is nothing else but option A, which is, that is, there is failure of migration of neural crest cells in the distal gut. And as the neural crest cells could not migrate till the distal gut beta, that's the reason the ganglionic cells were not present in the distal gut in both the plexuses, Myenteric as well as Meissner's beta. Clear? So the answer to this question is nothing else but beta. It is okay, I'll keep that in mind. So here the cause is nothing else but option A, that is failure of migration of neural crest cells in the distal gut. That is the cause for Hirschsprung's disease. Now, important is, I'll share the PDF, don't worry, in the NLC Telegram group. You can definitely get the PDF after the session, the annotated one, so you don't have to worry about it. Clear? Now, important to be remembered is one thing: in patients of Hirschsprung's disease, what can be done to confirm the diagnosis? So we know beta, to confirm the diagnosis of Hirschsprung's, one, we can go for barium enema or the contrast enema. Reason: this barium or contrast enema can tell me about the extent of disease beta. That is, how much segment is aganglionic, or how much segment is affected, or how much segment is collapsed. That I get to know with the help of a barium enema or a contrast enema. Whereas, to see whether the ganglionic cells are present or absent, I have to do a rectal biopsy. Reason: when I'll do a rectal biopsy beta, then I'll get to know whether the ganglionic cells are present or absent in the distal gut. Clear? So rectal biopsy can definitely confirm my diagnosis. That has to be remembered. And lastly, treatment if they ask you. We know in cases of Hirschsprung's disease beta, we have to cut the segment which is aganglionic and we have to join the segments which are normal. ठीक है, तो cut the aganglionic segment or resect the aganglionic segment and join the normal segment. That is known as resection and anastomosis, beta. But do remember, the resection and anastomosis is done by various surgeries. There are various surgeries that we have for Hirschsprung's disease. The first one that we have is called as the Duhamel's operation. Okay, the first one is known as the Duhamel's operation. Second one can be called as the Swenson's operation or the Swenson surgery, beta. Okay, and the third one is known as the Sovan-Parks operation or Sovan-Parks surgery, or you can even call it as the Sovan-Parks coloanal anastomosis. Clear? So do remember the three surgeries that are based on the principle of resection of the aganglionic segment and anastomosis of the normal ganglionic segment for Hirschsprung's disease are Duhamel's operation, Swenson surgery, or Sovan-Parks anastomosis. Hopefully clear. So these are the important things that you have to remember about Hirschsprung's disease, beta. Clear? Chalo. Next important, if I talk about now, is question number 2. Question number 2 says we are having a middle-aged female who presents to us with complaints like weight gain, along with decreased appetite, along with dry skin, and there is constipation, beta, from the last few years. Her lab workup reveals there is a low free T3 and free T4, but there is a high serum TSH levels, beta. And they are saying the female is having anti-TPO antibody titers which are elevated. Which among the following malignancy is more commonly associated with this given condition? Okay, please tell me first of all these symptoms which are there, they are going to be suggestive of hyperthyroidism or hypothyroidism. This is not the only thing that you have to revise. You have to go through your main notes, at least the important topics of your main notes. These are basically to understand the MCQ solving part. Okay, you can find the revision PDFs in the groups as well. In NLC Telegram group and in my Telegram group, you can find the revision PDF that can be used for your revision. These are basically to understand the MCQ solving where most of you get stuck. So there is some issues with the technicalities. So that's the reason the question is not completely visible, but I have zoomed it out so you can easily see and read the question properly. So here, what is the likely diagnosis? Is it hyperthyroidism or hypothyroidism? Very good. It is a classical question of nothing else but hypothyroidism, beta, right? We know, as they mentioned, the patient is having weight gain or obesity, as there is a decreased appetite, as there is dry skin, beta, or there is decreased GI motility causing constipation. So we know, and they have clearly mentioned there are low T3 and low T4 levels. So all of these are definitely suggestive of hypothyroidism in the patient. Please tell me, what is the most common cause of hypothyroidism worldwide? I hope all of you are quite aware. The leading cause of hypothyroidism worldwide. We know with all these symptoms, I know it is a diagnosis of hypothyroidism. Okay. Now, the leading cause of hypothyroidism worldwide, if they ask you, I hope all of you are quite aware. Here they have clearly mentioned that the patient is having high TSH levels that can be seen in patients of hypothyroidism, beta. Why? Because we know whenever there is hypothyroidism, there is decreased production of T3 and T4 by the thyroid gland. As there is low T3 and T4 in the body, there is no negative feedback to the pituitary. And as there is no negative feedback, pituitary keeps on secreting more and more amount of TSH. So do remember, low T3, T4 and high TSH is always suggestive of hypothyroidism in the patient. Clear? Now here they have clearly mentioning, beta, that anti-TPO antibody titers are elevated, and I hope all of you are quite aware. Anti-TPO antibody titers, as soon as they say they are elevated, we know the diagnosis has to be Hashimoto's thyroiditis. Do remember, the most common cause or the leading cause of hypothyroidism worldwide is usually Hashimoto's thyroiditis, beta. Yes, only in underdeveloped countries usually it is iodine deficiency, right? Because majority of the countries do take iodized salt in their diet. That's the reason, beta. The leading cause for hypothyroidism worldwide is Hashimoto's thyroiditis, or also known as chronic lymphocytic thyroiditis. Only in underdeveloped countries it is iodine deficiency. Hopefully clear. And as soon as they said anti-TPO antibody levels are high, we know it is Hashimoto's thyroiditis. Do remember, it is also called as chronic lymphocytic thyroiditis. I'm telling you this because in a PYQ of NEET PG examination, instead of writing Hashimoto's thyroiditis in the option, they have written chronic lymphocytic thyroiditis as one of the options. So do remember, whether they write Hashimoto's or they write chronic lymphocytic thyroiditis, it is one and the same thing, beta. That has to be kept in mind. Hopefully clear to all of you now. So these are the points that you have to keep in mind. Done with this. In cases of Hashimoto's thyroiditis, which are the two malignancies associated? So do remember, One cancer that is associated with Hashimoto's thyroiditis is the papillary thyroid carcinoma. So one is definitely the papillary thyroid cancer beta, and second thyroid malignancy that is associated with sorry, Hashimoto's thyroiditis is nothing else but beta the thyroid lymphoma. So one is definitely the papillary thyroid cancer, and second one is basically a thyroid lymphoma. These two are the commonest malignancies which are associated with Hashimoto's thyroiditis in a patient. Hopefully clear. Now let's see one by one. Option mein, are you having any papillary thyroid cancer as the option? No. If papillary thyroid cancer was one of the options, I would have marked papillary thyroid cancer. But as papillary thyroid cancer is not there, that's the reason basically beta, my answer to that question has to be nothing else but option B, that is a thyroid lymphoma. This is also a malignancy that is associated commonly with Hashimoto's thyroiditis beta. Hopefully clear. That is what is important. Follicular thyroid carcinoma is not associated with Hashimoto's thyroiditis. It is rather associated with iodine deficiency or multinodular goiter. But here they did not give any history of multinodular goiter in the female. They did not mention anything regarding iodine deficiency as well. Rather, they gave anti-TPO antibodies which are suggestive of Hashimoto's. Next is medullary thyroid carcinoma. Medullary thyroid carcinoma is due to red gene mutation or the MEN2 syndrome, but no history of MEN2 syndrome, so option C cannot be the answer. Anaplastic thyroid cancer, we all have discussed in main notes also that anaplastic thyroid cancer is usually seen in very old patients around 7th or 8th decade of life beta. Clear? So, and it is not associated with Hashimoto's again. Clear? So that is what is important. In patients of Hashimoto's thyroiditis, you can see this classical picture. First of all, you can see these intensely eosinophilic or pinkish cells beta, and these are classically referred to as the Hurthal cells. Apart from that, you can see a lot of lymphocytes or a lot of lymphocytic infiltration beta, which is seen inside the thyroid follicles. So you are able to see a lymphoid follicle means there is excess lymphocytes inside the thyroid follicle beta, and that is because of this chronic inflammation or this lymphocytic infiltration beta. That's the reason why we call Hashimoto's thyroiditis also as chronic lymphocytic thyroiditis. Hopefully clear. That is what is important. In cases of Hashimoto's thyroiditis, we all know, as it is a case of hypothyroidism, treatment is nothing else but you have to keep the patient on a lifelong levothyroxine supplementation. Right? We have to keep the patient lifelong on a levothyroxine supplementation. That has to be kept in mind. Okay? So lifelong levothyroxine supplementation has to be given, and we have to start from very low doses beta, and gradually you have to increase the dose of levothyroxine. That was also a question, that whether you start at high doses or low doses. Always start levothyroxine with very low doses, and then gradually or slowly increase the dose of levothyroxine. Clear? Now important, I can just give you all the thyroid cancers in one table. At least revise this table, it will be enough. Okay, so understand. First of all, papillary thyroid cancer beta. We all know that papillary thyroid cancer is considered as the most common thyroid cancer among all. Okay, the most common primary thyroid cancer has to be papillary thyroid cancer. We know that papillary thyroid cancer which is there, it is going to be more commonly seen in younger patients beta. And when I say younger patients, that means around 20 to 40 years of age, right? Papillary thyroid cancer is more common in the younger patients between 20 to 40 years of age. Whereas papillary thyroid cancer is going to be associated commonly with malignancies like, with risk factors like, first is radiation exposure. So if you had a previous history of radiation exposure, that can cause papillary cancer. Second, with a history of thyroglossal cyst. If you had a history of thyroglossal cyst, that can increase the risk of papillary cancer. And third, Hashimoto's thyroiditis. So radiation exposure, thyroglossal cyst, and Hashimoto's thyroiditis are the three important risk factors associated with papillary thyroid carcinoma. We know that papillary thyroid cancer arises from the follicular cells itself. So it is a differentiated cancer arising out of the follicular cells, and the tumor marker for all the thyroid malignancies which arise from the follicular cells, the tumor marker has to be serum thyroglobulin beta. So the tumor marker for a case of papillary thyroid cancer has to be serum thyroglobulin. Do you remember that? Next, metastasis, if they ask you, we know commonly the papillary thyroid cancer metastasizes or spreads via the lymphatic route. Okay, so lymphatic metastasis is common in cases of papillary thyroid cancer, and it mainly metastasizes or it mainly spreads to the level 6 lymph nodes or the central lymph nodes in the neck beta. Clear? Next important is PYQ and NEAT-PG, which is the gene mutation associated with papillary thyroid cancer. So answer has to be the BRAF gene mutation. The BRAF gene mutation is commonly associated with papillary thyroid cancer itself. And we all know among all the thyroid malignancies, papillary thyroid cancer has the best prognosis. Papillary has the best prognosis among all the thyroid malignancies, has to be remembered. And we all know that papillary thyroid cancer mein, the treatment is nothing else but you can go for a total thyroidectomy along with lymph node dissection. So total thyroidectomy plus lymph node dissection is the treatment. And once you do a biopsy in cases of papillary thyroid cancer, that biopsy shows you this classical Sarkari feature in the histopath beta. And what is seen? The malignant cells of papillary thyroid cancer which are there, they are going to have an empty nucleus, right? The malignant cells of papillary thyroid cancer have an empty nucleus, and that is classically known as your Sarkari image, that is orphan annii nuclei appearance, right? So we know whenever they give a picture of histopath which is showing you empty nuclei, that is known as orphan annii nuclei appearance, always think about the diagnosis of papillary thyroid carcinoma. Okay, always think about the diagnosis of papillary thyroid carcinoma. Apart from that orphan annii nuclei appearance on histopath, we know as it is a papillary cancer, all the papillary cancers of the body can show us the classical calcified lamellated bodies known as Samoma bodies. Calcified lamellated bodies known as Samoma bodies. Anybody, let me know in the chat box. Samoma bodies are an example of metastatic calcification or dystrophic calcification. PYQ NEET. Metastatic or dystrophic calcification. Samoma bodies are an example of which type of calcification? Let me know. So Samoma bodies are seen on the histopath beta. Along with that, papillae or finger-like projections will be seen. So if any histopath shows you papillae, orphan annii nuclei appearance and Samoma bodies, always think about papillary thyroid carcinoma. Clear? So hopefully you are clear. Next important is follicular thyroid cancer. Do you remember follicular thyroid cancer is the second most common thyroid malignancy overall? Yes, the second most common thyroid cancer overall is the follicular thyroid cancer, and it is more commonly seen in older patients, usually more than 50 years of age. It is more common in older patients more than 50 years of age. And do remember one point, that follicular thyroid cancer is commonly associated with multinodular goiter beta or iodine deficiency. If they give you history of multinodular goiter or iodine deficiency in the patient, if they give you history of multinodular goiter or iodine deficiency in the patient, always think about the diagnosis of follicular thyroid cancer beta. Clear? So that is what is important to be remembered. No issues with this. Next important if I talk about is if they ask you it originates from what. So do remember beta, it usually originates from nothing else but the follicular cells. Again, it is a differentiated thyroid cancer arising from the follicular cells beta. That is what is important. If they ask you what is the tumor marker, so again as it arises from follicular cell, here also the tumor marker is nothing else but serum thyroglobulin beta. Here also the tumor marker is going to be serum thyroglobulin. Clear? So that is what is important to be remembered. Understood? If they ask you what is the spread, so I hope all of you are quite aware, follicular thyroid cancer, though it is a carcinoma, although it is an epithelial malignancy, it commonly does not spread via the lymphatic route beta. It commonly spreads via the hematogenous route or the blood route. And please tell me, whenever follicular thyroid cancer commonly spreads via the hematogenous route beta or the blood route, it is going to cause which kind of metastasis? Very classical. Follicular thyroid cancer, whenever it spreads via the hematogenous or the blood route, it classically causes which type of metastasis? Let me know that in the chat box. Do remember? Yes, Samoma bodies are an example of dystrophic calcification. Shabash all of you. That is the right thing. Follicular thyroid cancer, when it spreads via hematogenous route, it commonly leads to which one? Let me know in the chat box. Anybody? It leads to a pulsatile bony mets beta. No, it does not spread to lungs. Commonly it spreads to the bones beta. Okay, and it classically causes a pulsatile bony metastasis. That is the keyword of the question. Okay, pulsatile bony metastasis is seen with two cancer. One is definitely the follicular thyroid cancer, and secondly, it is actually going to be the renal cell carcinoma. Yes, it is going to be pulsatile bony mets, which is seen in follicular thyroid cancer and renal cell carcinoma. Do remember both of them. Next, the gene mutation associated with follicular thyroid cancer is known as KRAS. We know KRAS gene mutation is associated with follicular thyroid cancer, second, colorectal cancer, third, pancreatic cancer. So follicular thyroid cancer, colorectal cancer and pancreatic cancer are the conditions where basically the KRAS gene mutation is going to be associated with. And do remember, it is going to have a poor prognosis beta. Okay, follicular thyroid cancer happens usually in older patients more than 50, and it is usually associated with a poor prognosis. That has to be remembered. Okay, important is in cases of follicular thyroid cancer, we know the treatment is only a total thyroidectomy beta. Okay, usually a lymph node dissection is not needed. Why? Because follicular thyroid cancer does not commonly spread by the lymphatic route, so we mainly go for a total thyroidectomy. Okay, lymph node dissection is usually not needed. And once you do the total thyroidectomy, the histopath will show you the classical feature beta, and that is nothing else but the capsular and the vascular invasion. If the histopath shows you pinkish or eosinophilic cells along with capsular and vascular invasion, that is a diagnostic feature of follicular thyroid cancer. Do remember that FNSC which is there, it is never useful in the diagnosis of follicular thyroid carcinoma. So that is what is important. I have been telling you that for a long time now. This has been a PYQ also. FNSC or a fine needle aspiration cytology is not diagnostic of follicular thyroid cancer, because FNSC cannot differentiate whether it is a follicular carcinoma or a follicular adenoma beta. Okay, as it cannot differentiate between a benign and a malignant tumor, therefore FNSC is not useful. It has been a repeated PYQ in both FMG as well as NEET PG. So for diagnosis and follicular thyroid cancer, only a biopsy is needed. So we do a thyroidectomy, and after doing the thyroidectomy, then we send a biopsy. Only that biopsy is confirmatory for a follicular thyroid carcinoma, has to be remembered. Clear yahan tak? Next important if I talk about is medullary thyroid cancer. Medullary thyroid cancer which is there beta, we have discussed that it is commonly associated with the red gene mutation, and it is associated with MEN2 syndrome, right? So we know there are MEN2 syndromes like MEN2A, which is also called as the Sippel syndrome, or MEN2B, which is also known as Gorlin syndrome. So this MEN2A and MEN2B syndromes are commonly associated with medullary thyroid carcinoma. And we all know that medullary thyroid carcinoma which is there beta, it is actually a neuroendocrine tumor. And as it is a neuroendocrine tumor beta, therefore, as it is a neuroendocrine tumor beta, that's the reason definitely we all know it is going to have excess secretion of serotonin beta. Okay, it is going to have excess secretion or excess production of serotonin in the body. So if they ask you that serotonin syndrome is associated with, so do remember that serotonin syndrome is commonly associated with medullary thyroid carcinoma beta. Clear? And we know as medullary thyroid carcinoma has serotonin syndrome, therefore it is actually going to cause it is actually going to cause problems like flushing, wheezing and diarrhea. So if they say patient is having a thyroid mass along with flushing, wheezing and diarrhea like symptoms, think about serotonin syndrome and think about medullary thyroid cancer as the diagnosis. Important is, as the patient suffers from serotonin syndrome, please tell me which metabolite levels you should check in the patient's urine. Let me know to diagnose a case of serotonin syndrome, or to confirm that the patient is having serotonin syndrome, which metabolites are you going to check in the patient's urine sample, PYQ and FMG. Let me know that in the chat box. We know that medullary thyroid carcinoma is the only thyroid malignancy which does not arise from the follicular but arises from the parafollicular cells beta. It is basically going to arise from the parafollicular cells, or the parafollicular C cells to be specific, right? It arises from the parafollicular cells, also called as the parafollicular C cells to be specific. And we all know here in this cases of medullary thyroid carcinoma, the best tumor marker which is there, it is nothing else but serum calcitonin, right? So serum calcitonin is considered as the best tumor marker in patients of medullary thyroid cancer. Again, another PYQ was asked. Tumor marker for medullary thyroid cancer, answer has to be serum calcitonin. Next important, it spreads by both the route. It can actually spread via the lymphatic route as well as the hematogenous route. So by lymphatic metastasis, it spreads to the level 6 lymph nodes or the central lymph nodes in neck. But by hematogenous route, it commonly spreads to the liver. Via the hematogenous route, it commonly spreads to the liver beta. And we have discussed that it is associated with red gene mutation. Therefore, it is a part of MEN2 syndrome beta. That has to be remembered. And it has a moderate prognosis. It has an average prognosis beta. Not too good, not too bad. Clear? Do remember? Very good. Yes, it is 5-HIAA. That is 5-hydroxyindolacetic acid. So any neuroendocrine tumor which causes serotonin syndrome or excess production of serotonin in the body beta, in that condition, excess levels of 5-HIAA will be noted in the patient's urine. The 5-hydroxyindolacetic acid will be high in the patient's urine if he is suffering from serotonin syndrome. That was the PYQ. In cases of medullary thyroid cancer, if you see the histopath, that is, treatment is again a total thyroidectomy with lymph node dissection. As we do a total thyroidectomy with lymph node dissection, after thyroidectomy, when we do a histopath, this classical picture is seen. Can you see these are the malignant cells beta, but in between them this is the stroma, and in that stroma we are able to see excess amount of pinkish appearance, and that stroma is appearing pink in color basically beta, and that is because of nothing else but sorry excess amount of amyloid rich deposits, right? So you can see there is an amyloid rich stroma or excess amyloid deposits which are seen on the histopath. So an amyloid rich trauma or amyloid rich deposits are seen on the histopath, and that confirms the diagnosis of medullary thyroid carcinoma. As we all know that amyloid rich trauma is seen or amyloid deposits are seen beta. That's the reason the stain that we use over here is the Congo red stain. And as we use the Congo red stain on the histopath, you can see this pink amorphous amyloid deposits. Hopefully clear. Which amyloid is deposited in patients of medullary thyroid carcinoma? Let me know in the chat box. Another question, if I integrate with patho, which amyloid deposits are seen in cases of medullary thyroid carcinoma? Let me know in the chat box. Anybody? Which kind of amyloid is deposited in medullary thyroid carcinoma? So do remember the amyloid that is deposited in patients of amyloid thyroid carcinoma, medullary thyroid carcinoma is nothing else but ACAL. So it is basically the ACAL amyloid. Very good. Yes, shabash. It is the ACAL amyloid which is deposited. Okay. Next important, the last one is anaplastic thyroid cancer. And if I talk about an anaplastic thyroid cancer, do remember beta that this anaplastic thyroid cancer which is there, it is going to be commonly seen in 7th to 8th decade of life beta. We all know that anaplastic thyroid cancer is seen in very old patient around 7 to 8 decade of life. And in this condition, the patient comes to us with complaints of rapidly progressive thyroid swelling, and this rapidly progressive thyroid swelling is commonly associated with pain, and on palpation that swelling is very hard beta. Apart from that, it also originates from follicular cells. We know anaplastic thyroid cancer is the only undifferentiated cancer that arises from the follicular cells of thyroid gland. Do remember, as it arises from the follicular cell, here also the tumor marker is going to be serum thyroglobulin. Here also the tumor marker is going to be serum thyroglobulin itself. We all know it can spread by both the route. Again, the metastasis in anaplastic thyroid carcinoma can be seen via the lymphatic route as well as the hematogenous route. Okay, so by the lymphatic route, it commonly spreads again to the level 6 lymph nodes or the central lymph nodes in the neck. But by hematogenous route, it commonly spreads to the lungs beta. Okay, by hematogenous route, it commonly spreads to the lungs. And the gene mutation associated with anaplastic thyroid cancer is going to be P53. The Sarkari gene mutation associated with most of the cancers in body, that is P53. So P53 gene mutation is associated with anaplastic cancer, and it has the worst prognosis among all the types of thyroid cancer. Among all thyroid cancer, worst prognosis is seen with anaplastic. So best prognosis was a feature of papillary, worst prognosis is a feature of anaplastic cancer. That has to be kept in mind. Treatment is, even if the anaplastic thyroid cancer is limited to the thyroid gland, still we go for total thyroidectomy plus central neck dissection plus modified radical neck dissection. So you remove all the lymph nodes beta if the patient is having anaplastic thyroid cancer. Clear? That was all about your thyroid cancers in one go. Now let's talk about question number 3, which says identify the incorrect pair of the flaps and the condition where it is used. So now these kind of questions are more commonly asked in NEET, but just for information's sake, I've told you flaps were a favorite question of your FMG examiners for almost 3 or 4 examinations. Okay, so do remember here they are saying one by one. Let's see. First is option A says rhomboid flap. Rhomboid flap used for the treatment of basal cell carcinoma. Is it true or false? Please tell me. T for true, F for false. Keep on commenting. Now if I talk about option A, it says rhomboid flap used for the treatment of basal cell carcinoma beta. Let me know in the chat box. Anybody? Please tell me. Is it true or false? So do remember, rhomboid flap is used for the treatment of basal cell carcinoma. Yes, that is a true statement. Okay, if there is a larger area having a basal cell carcinoma on the face beta, you have to do a wide local excision, and after doing wide local excision, you can place a rhomboid flap in that area beta. So that is a true one. Next important is option B says bilobe flap. It is used for the tip of nasal reconstruction. Is it true? So yes, we all know that this was a PYQ also in the FMG examination. Image based question was there. Bilobe flap, yes, it can be used for the nasal tip reconstruction beta. Right? If you want to do a reconstruction and on the tip of the nose. Again, usually due to basal cell carcinoma, we tend to use the bilobe flap. Bilobe flap for nasal reconstruction, bipedicled flap for eyelid reconstruction. Beta, we have discussed that in class as well. Clear? Next is option C says beta Viviplasty used for the treatment of post-burn contractures. Is it true or false? Let me know in the chat box. Viviplasty, do we use it in the treatment of post-burn contractures? We know if the patient is having, we know that if the patient is having the 3rd degree or 4th degree burns beta, so in those conditions there can be contractures after healing. And to treat those contractures, we have to go for plastic surgery. So we know that is also true because Viviplasty can be the plastic surgery used for the treatment of post-burn contractures. Yes, so that is what is important to be remembered. Viviplasty is not only for one surgery. Viviplasty and Z-plasty are the surgeries which can be done for multiple indications. They can be used whenever you have to lengthen the length of the wound or whenever you have to increase the length of the wound beta. They can be done in any cases of contractures or scars as well. Clear? So it is not only one for one thing. That has to be remembered. Option D is a false statement beta because option D says PMMC flap, that is pectoralis major myocutaneous flap, used for breast reconstruction. Absolutely not. We know in a lot of times beta, while doing a mastectomy or a modified radical mastectomy, we also remove the pectoralis major muscle. Then how we will use the pectoralis major myocutaneous flap beta for the breast reconstruction, right? For breast reconstructions, the flaps that we use beta are usually taken from the abdominal wall, right? We have discussed about the flaps like the TRAM flap, transverse rectus abdominis myocutaneous flap, or the DIEP flap, deep inferior epigastric artery perforator flap. Those TRAM and DIP flaps are the ones which are used for breast reconstruction. Okay, even LD flap or latissimus dorsi flap is used, but never the PMMC flap. PMMC flap, which is taken from the chest wall, that is basically used for a case of an oral cancer. When the patient had an oral cancer and that patient has undergone an oromandibular dissection or commandos operation. After that commandos operation, we take the flap from the chest wall, that is PMMC flap or the deltopectoral flap, right? So that is important. Very good. So answer to that question is option D, that is incorrectly matched. PMMC flap is not for the breast reconstruction surgery. Here you can see, this is the flap that you are able to see, a flap, a horizontal or a transverse flap taken from the patient's abdominal wall or the rectus abdominis muscle beta for the reconstruction of the breast. So this one that you are able to see in the picture, this is actually a picture of a TRAM flap. That is nothing else but the transverse rectus abdominis myocutaneous flap. And you are all quite aware that TRAM flap which is there, it is going to be the most commonly used flap beta in patients of breast reconstruction. The most commonly used flap in case of breast reconstruction is the TRAM flap. Next important if I talk about is nothing else but the DIEP flap. The next one that we have is basically called as the DIEP flap beta. And one thing that you have to remember, that this DIEP flap which is there, it is going to be the best flap to be used for breast reconstruction surgery. The DIP flap is the best flap to be used for the breast reconstruction surgery. Please tell me one point. Why is the TRAM flap not the best flap to be used for breast reconstruction surgery? So after doing a mastectomy, why is the TRAM flap not the best flap to be used for the breast reconstruction surgery? Let me know in the chat box. Bolo. Silicone implants can be used, but a lot of times people don't want silicone implants basically because they can be associated with some complications. Clear? So, breast reconstruction is done by two ways. One, by using alloplastic implants like the silicone gel implants or silicone implants with saline refills. But a lot of times they are done with the autologous flaps from the patient's own body. Okay, and those can be the flaps like DIP, TRAM or LD flap. Very good, because once you raise the TRAM flap or once you harvest the TRAM flap from the abdominal wall will become weaker beta, and that increases the risk of an incisional hernia. Very good, shabash. As it increases the risk of incisional hernia, it is not the best flap to be used for the breast reconstruction surgery beta. Okay, but it is more commonly used because it is easier to harvest. Okay, and why it increases the risk of hernia? Because we know here we don't only take the skin and the subcutaneous fatty tissue, we also take the rectus abdominis muscle. That's the reason the abdominal wall becomes weaker. In DIP flap, you do not take any muscle, you only raise the skin and the subcutaneous fatty tissue. Therefore, it does not have any risk of abdominal wall hernia or incisional hernia. Clear? Great. Next important, if I talk about basically beta. Thank you so much, sir. Means a lot. Next important, if I talk about is this one here, you are able to see that this is a picture of a basal cell carcinoma. And as you can see, a basal cell carcinoma, we are removing or we are excising the part beta which is having the basal cell carcinoma. And once doing a once we have done a wide local excision, after that, then you have to raise this kind of a flap. This is a bilobe flap, and then you just have to turn the axis of this bilobe flap, and you have to cover the exposed area beta. Okay, so this is the classical bilobe flap, and you can see the bilobe flap is basically used for the reconstruction of the nose, right? The bilobe flap is basically used for the reconstruction of the nose beta in the patients who are suffering from basal cell carcinoma, right? So that is what is important. Next important is this picture. You can see this was a previous year image based question, twice asked in the FMG and NEET PG exams. Here you can see there is a rhomboid shaped flap that we are raised. Okay, and we know here you can see these are the buttocks of the patient. This is the natal cleft beta. This butt crack is basically called as the natal cleft. And in this natal cleft, you are going to have pilonidal sinuses, right? There are pus discharging sinuses or the pilonidal sinuses which are present in that butt crack or in that natal cleft. So here what we have done, here basically beta, to cover that area, we have raised a rhomboid shaped flap and we have just turned the axis of that rhomboid shaped flap. As you turn the axis of the rhomboid shaped flap, you cover the area which is actually having the pilonidal sinuses beta. Clear? So this is known as the rhomboid flap or the Limburg flap. And I hope all of you are quite aware that rhomboid or Limburg flap, if they ask you that is done for which condition. So either they'll give you the picture and ask you the name of the flap. So do remember it is a rhomboid or a Limburg flap. And if they ask you it is done for which condition, so now you know it is done mainly for pilonidal sinus surgery, or similar kind of rhomboid flap beta can also be used on face, but that is for the basal cell carcinoma. So rhomboid flap is not only used in the natal cleft area for pilonidal sinus, it can also be used on the face beta for the basal cell carcinoma that I've already told you. Clear? Next important is this. This is the flap that we have taken from the patient's chest wall, as you can see, and then we have covered this exposed area on the face of the patient. So once the patient has undergone the oromandibular dissection for oral cancer, then we have placed this flap. This is the classical picture of PMMC flap or the pectoralis major myocutaneous flap. And this PMMC flap or pectoralis major myocutaneous flap is generally used in patients of oral cancer for an oromandibular dissection or after a commandos operation. For an oromandibular dissection or after a commandos operation. Hopefully clear to all of you now. So these are the important things beta that you have to remember about the flaps. The commonest flaps that are used. Okay, at least remember these ones. You will be done with the flaps. Hopefully clear. That is important. Next is question number 4. Question number 4 says we are having a 17-year-old boy who presented to us with complaints like abdominal pain that is localized in the right lower quadrant. Along with that, patient is having loss of appetite and the patient is having history of almost 2 to 3 vomiting episodes beta the same morning. On per abdominal examination, tenderness was elicited in the right iliac fossa. Tenderness was elicited in the right iliac fossa and it aggravated as the pressure was released. Okay, the tenderness aggravated as the pressure was released. Lab workup reveals hemoglobin is 10.5 grams per deciliter. Total leukocyte count is 15,000 cells per cubic millimeter and platelets are 3 lakh cells per cubic millimeter. What will be the Alvarado score of this patient according to the given information? So now that is what is important to be remembered. They're asking you what is going to be the total Alvarado score or the Mantel score of this patient. Now, whenever this patient comes to you, like a 10 to 25-year-old patient, right? A 10 to 25-year-old boy coming to you with complaints like abdominal pain or the right lower quadrant or right iliac fossa pain, along with loss of appetite or anorexia, along with nausea, vomiting, along with tenderness in the right iliac fossa or the right lower quadrant, and the rebound tenderness, leukocytosis. So we all know we have to think about nothing else but acute appendicitis. And whenever we think about acute appendicitis, the score that we basically use to see whether the patient is having a chance of appendicitis or not, that is classically called as an Alvarado score, also called as the Mantel score. So here we are suspecting acute appendicitis in the patient, and to make our suspicion more stronger, we have to check the patient's Alvarado score or the Mantel score. And we know Mantel's is basically an abbreviation of the 8 parameters that we have in the Alvarado score. And what are these 8 parameters of Mantel's or Alvarado score? M stands for migration of pain to the right lower quadrant or migratory pain in the right iliac fossa. Please tell me, we all know that in cases of acute appendicitis, the pain migrates till the right iliac fossa, or the pain comes till right iliac fossa. but the pain starts from umbilicus, right? So in acute appendicitis, the pain starts from the umbilicus and then it migrates to the right iliac fossa. What is the reason? PYQ again in the examination. So the question was, what is the reason for migration of pain from the umbilicus till the right iliac fossa in patients of acute appendicitis? Let me know in the chat box. Okay, so migration of pain to the right lower quadrant is given a score of 1 beta. Next, A for anorexia. Anorexia is given a score of 1, that is loss of appetite. Next, N for nausea and vomiting. Nausea and vomiting is given a score of 1 beta. Next, T for tenderness in the right iliac fossa. Tenderness in the right lower quadrant or right iliac fossa is given a score of 2. Next, R for rebound pain or rebound tenderness. That means when you are palpating the abdomen, at that time the patient does not have much pain, but as you release, now the patient has more pain beta. That is known as rebound pain or rebound tenderness, called as the Blumberg sign, right? That is given a score of 1. Next is E for elevated temperature of fever. That is given a score of 1. L for leukocytosis, that is to increase total leukocyte count or the increased WBC count. That is given a score of 2. And as for shift of WBCs to the left, that is more number of immature neutrophils are seen in the blood circulation. That is given a score of 1. We know in Mantel's parameter beta, all the parameters have a score of 1 except L and T. We all know L and T are the only two parameters beta which actually have a score of 2. Leukocytosis and tenderness. Hopefully clear? All of you are right. Yes. We all know beta that the reason for the migration of pain from umbilicus to right iliac fossa is the T10 dermatome. Very good. Shabash. It is the T10 dermatome which is the reason for migration of pain from the umbilicus till the right iliac fossa. Very good. That has been a PYQ. Now the total score of Mantel's is going to be 10. But we know one thing, that whenever the patient score is 9 or 10, we know the diagnosis of acute appendicitis is almost certain. Whenever the score will be either 9 or 10, that means the diagnosis is almost certain. When the score is 7 to 8, then it is highly suggestive of appendicitis beta. Whenever the score is going to be 7 or 8, then it is highly suggestive of appendicitis in the patient. Clear? Whereas if they say the patient's Mantel score or the Alvarado score is 5 or 6, then the patient is having equivocal chances of appendicitis. Equivocal matlab 50-50% chance you can say, or it may or may not be appendicitis. हो भी सकता है, नहीं भी हो सकता, right? So that is important to be remembered. So 5 or 6 means equivocal chances of appendicitis, and less than 5 is appendicitis is very unlikely in the patient. Okay, less than 5 Mantel score is suggestive of an unlikely case of appendicitis. Now, whenever in which score you should always send the patient for a CACT abdomen. Let me know in the chat box which is that Mantel score where we have to send our patient always for a CECT abdomen. Till that time, I'll calculate the score. You have given your answers. So let's see is the answer right or wrong. First of all, they have said patient is having abdominal pain in the right iliac fossa. So we know first the patient is having pain in the right iliac fossa. That is definitely a score of 1 beta. Clear? Next, the patient is having loss of appetite. That is anorexia. That is another score. That is another parameter having a score of 1. Next, they have also said patient is having vomiting. So, next important, there is tenderness in the right iliac fossa. Then again 2 score is there. They have said that the tenderness is aggravated as the pressure is released beta. That means there is a rebound tenderness which is seen, or there is a Blumberg sign which is there beta. So even rebound pain or rebound tenderness is there. And lastly, in the lab workup, they have clearly mentioned that there is an increased total leukocyte count. We know the normal leukocyte count or normal WBC count is 4,000 to 11,000 cells per cubic millimeter. Here definitely beta the patient score is 15,000. So obviously it is a leukocytosis ka case. So here if you see, it is going to be 8 score is going to be there beta, right? So therefore the answer to this question has to be nothing else but option B, that is a score of 8. Because a lot of people have not calculated this rebound tenderness beta. They have clearly mentioned that there was an aggravation of pain as the pressure was released beta. That is what is suggestive of rebound tenderness, right? So that is what is important. You should not miss out the small points beta. They are going to be important. Very good. Whenever the patient score is 5 or 6 or there are equivocal chances of appendicitis, then a CECT abdomen is mandatory. Reason, see, if the patient is having a score of 7, 8, 9 or 10, then obviously we know it is an appendicitis case and we have to go for a surgery, that is an appendectomy. But when the score is 5 or 6, a lot of time what can happen, if I only do an ultrasound abdomen, I may miss out on the diagnosis of acute appendicitis. And let's say you only did ultrasound, you thought that it is not likely to be an appendicitis case, you send that patient home. But actually the patient was having an acute appendicitis, and next day the patient comes to you in a very severe condition beta, because there was a perforation of that inflamed appendix. Clear? So that's the reason whenever the score is 5 or 6 and you are not sure, better go for a CCT abdomen to rule out acute appendicitis. Hopefully clear? So that is important. Understood? Chalo. Next is question number 5. We are having a question which states a young patient who was chronically malnourished beta was admitted in the ICU and started on TPN or total parenteral nutrition. 24 hours after initiating the total parenteral nutrition, the patient starts experiencing complaints like generalized weakness along with confusion, vomiting, and non-pitting edema in the legs. They are asking you which among the following is the driver abnormality in this case. Which among the following is the main problem or the main abnormality in this condition. What is the classical diagnosis? I hope all of you are quite aware. We have discussed that a lot of times, even in biochem and as well as surgery, that whenever a person is started on TPN or total parenteral nutrition and starts having complaints like, whenever a chronically malnourished patient was started on TPN or total parenteral nutrition, okay, what happens is, we know the patient suddenly goes from a catabolic state to anabolic state beta. Okay, he was chronically malnourished, so he was in a catabolic state. Suddenly, as he was given a lot of glucose or a lot of TPN, the patient goes into that anabolic state, and then he starts experiencing symptoms like generalized weakness, confusion, vomiting, and non-pitting edema. So we all know it is a classical diagnosis of refeeding syndrome beta. Okay, that's the reason it is said that whenever a person is chronically malnourished beta, okay, and that's the reason it is said that whenever a patient is chronically malnourished, you should not start that patient suddenly on a total parenteral nutrition or high amount of nutrition beta. Clear? So the diagnosis is refeeding syndrome. In cases of refeeding syndrome, if they ask you what is going to happen, understand. As the patient was having chronic malnutrition, his body was in a state of catabolism. Therefore, there was low levels of insulin and high levels of glucagon in the body. What happened suddenly is, we know, as there was catabolic state, so there was more glycogen breakdown, that is glycogenolysis. There was more breakdown of proteins or protein catabolism. There was more amount of gluconeogenesis in the body. And due to all of this beta, there was deficiency of vitamins and minerals in the patient's body. Now, we did refeeding. But problem was, as we did refeeding beta, we suddenly gave a lot of TPN to the patient or a lot of carbohydrates to the patient. Right? So in the refeeding, as you give excess amount of carbohydrates to the patient, what happens is there is sudden rise in the insulin secretion. And as there is a sudden rise in the insulin secretion beta, patient immediately goes into a state of anabolism. And when the patient goes in the state of anabolism, patient is going to have problems like increase in the protein synthesis. There is going to be more sodium retention in the body. And as there is going to be more sodium retention in the body, we all know beta, the patient's extracellular volume is going to increase, causing the edema in the patient. Patient will have more uptake of glucose in the cells. There will be more use of thiamine in the body. So thiamine deficiency or B1 deficiency will be there. And there will be an intracellular shift of phosphate, magnesium and potassium. That is, all the phosphate, magnesium and potassium starts going inside the cell. So suddenly the levels of phosphate, magnesium and potassium in the blood is going to decrease beta. So patient will have electrolyte disturbances like hypophosphatemia, which is the main abnormality or the driver abnormality in refeeding syndrome. Patient may have hypomagnesemia, hypokalemia, thiamine deficiency or vitamin B1 deficiency, and salt and water retention in the body beta. Clear? So these are all the features which are going to develop if a patient is suffering from refeeding syndrome. Clear? So we know, can we see hypokalemia? Yes, we can see hypokalemia. Can we see hypocalcemia? Yes, we can see hypocalcemia. Can we see hypophosphatemia? Yes. Can we see hypomagnesemia? Yes. So all these electrolyte disturbances are seen in the patient. Therefore, patient will have generalized weakness or muscle weakness, respiratory depression, even cardiac arrhythmias beta, right? So the patient is going to have problems like muscle weakness. There is going to be respiratory depression. Even the patient is going to have a risk of cardiac arrhythmias beta. And as there is an acute deficiency of vitamin B1 or there is acute deficiency of thiamine in the patient's body beta, the patient is also going to develop lactic acidosis, right? The patient is also going to develop lactic acidosis beta. These are all the features that you are going to see in the patient. Hopefully cleared all of you now. So that is what is very, very classical. No issues with this? Understood? Okay? So these are the points that you have to keep in mind. Now, if they ask you what is the driver abnormality, answer is nothing else but option C, that is hypophosphatemia beta. That needs a correction immediately. Clear? So that is important. Understood? Now, which is the condition beta? Important from patho, medicine and surgery as well. Which is that condition where the patient will have hyperkalemia, hyperphosphatemia, hypermagnesemia, except hypokalemia. What is that? Sorry, hypocalcemia. Which is that condition where everything increases except calcium in the body? Let me know in the chat box. Another repeated PYQ, it has been in the examination. There is going to be hyperkalemia, hypermagnesemia, hyperphosphatemia, except hypocalcemia. Which is that condition? Let me know in the chat box. That condition is nothing else but tumor lysis syndrome. Whenever a patient of cancer or malignancy is given chemotherapy or anti-cancer drugs, after that, the patient develops these electrolyte disturbances, and that is classically known as the tumor lysis syndrome beta. That has to be kept in mind. Clear? In a patient who is suffering from refeeding syndrome, just remember one thing. If you don't want the patient to develop refeeding syndrome, what is done for prevention? So prevention ke liye, we have to gradually increase the amount of TPN, or you have to slowly increase the amount of TPN or total parenteral nutrition beta in a patient who is chronically malnourished. So gradually increase the amount of TPN or gradually increase the dose of total parenteral nutrition. And please remember, also make sure that you are giving IV thiamine to the patient. Yes, as the patient will have vitamin or thiamine deficiency and you directly give glucose, the patient might develop lactic acidosis, right? And next important, do a strict monitoring of electrolytes in the patient. Continuously monitor the patient's electrolytes beta. Clear? Next important, if I talk about, is question number 6, and that states a patient was morbidly obese beta and he has failed to lose the weight despite the lifestyle modifications as well as pharmacotherapy. So he has undergone a bariatric surgery. I hope all of you are quite aware, whenever a patient is going to have morbid obesity and that patient has failed to lose the weight despite trying the lifestyle modifications, that is dieting and exercise, and even after trying pharmacotherapy, that is GLP-1 analogs, drugs like semaglutide, liraglutide, Ozempic, okay? So definitely after even trying all those pharmacotherapy, if the patient definitely fails to lose the weight, then you have to go for a bariatric surgery, which is a weight loss surgery beta. Now they are asking you that which among the following bariatric surgery causes maximum weight loss beta? Which bariatric surgery causes maximum weight loss? I've told you this in the class as well. Please tell me which one causes maximum weight loss. I have told you there are some surgeries which are not in practice, but they are known to cause maximum weight loss. They are not in practice, but they are still known to cause maximum weight loss beta. They are not in practice because they are associated with some complications. Therefore, we don't prefer them. Do remember that if they ask you that which bariatric surgery is associated with maximum weight loss beta, do remember the answer has to be nothing else but option A, that is BPD with duodenal switch. I have told you biliopancreatic division with duodenal switch is the surgery, yes, associated with maximum weight loss. Shabash, very good both of you. It is going to be PPD with duodenal switch, has to be kept in mind. Clear? Do remember, yes, if they ask you which is the most effective surgery for bariatrics, so most effective surgery for bariatrics is definitely the Roux-en-Y gastric bypass surgery. Which is the most commonly done surgery in bariatrics? Yes, it is the sleeve gastrectomy. So sleeve gastrectomy is the most commonly performed surgery in bariatrics. But if they ask you maximum weight loss is associated, it is associated with BPD with duodenal switch. I'll be sharing the PDF once the session is done. Even the unannotated PDF has been shared in the NLC group. You can find the annotated PDF after the session in the NLC group itself. Clear? So that is important. Clear hai baat yahan tak? So do remember, we know the bariatric surgeries that we commonly do nowadays are, one is gastric banding, also called as laparoscopic adjustable gastric banding, where you apply an adjustable band around the patient's stomach beta, and with the help of this access port, the adjustable band is inflated. As you inflate the band, it is going to compress the stomach. And as soon as the patient's stomach gets compressed beta, we know the patient is actually going to have the patient is going to have decreased appetite beta. Reason is, if the patient tries to eat a lot of food after applying this gastric band or after inflating this gastric band beta, we know patient will immediately have vomiting or dumping syndrome like features. That's the reason the patient avoids eating a lot of food. Okay, so therefore the gastric banding can be done. But we know gastric banding also has some failure rates, but it is not always successful. That's the reason definitely. Please remember, here you can do another surgery, that is a sleeve gastrectomy. If I talk about sleeve gastrectomy, it is most commonly done bariatric surgery where we use the linear stapler and we apply this linear stapler along the greater curvature of stomach. As you apply the linear stapler along greater curvature of stomach, you have to cut out or you have to resect the part of the stomach along greater curvature. As you remove this part along the greater curvature, only a small part of the stomach is left, beta. That looks like a sleeve, right? So only a small gastric sleeve is going to be left behind. That is classically called as the sleeve gastrectomy. Here, as only a gastric sleeve is left behind, beta, obviously the patient's appetite is going to decrease and eventually the patient will have weight loss as well. Next important is this one. This is the classical Roux-en-Y gastric bypass surgery. When I talk about the Roux-en-Y gastric bypass surgery, what we do? We just create a small gastric pouch, beta, and we directly connect our jejunum to that small gastric pouch. Why? Because when we connect our jejunum directly to the small gastric pouch, what will happen? The food will come and it will go directly from the esophagus to the jejunum. As the food goes directly from the esophagus to jejunum, beta, we know here the food is actually bypassing the stomach as well as the duodenum. And as the food bypasses the stomach and duodenum, therefore we call it as the Roux-en-Y gastric bypass surgery. As the food will not go into stomach only, beta, the patient's appetite is going to decrease. You will be like, how? Reason is definitely, do remember, because as the food goes from esophagus to jejunum, beta, please remember, if the patient tries to eat a lot of food, immediately that excess food or large meals will get dumped inside the jejunum, and within 10 to 15 minutes of food intake, patient starts experiencing complaints like epigastric pain, epigastric fullness, vomiting, bloating. Okay, and that's the reason the patient is having these kind of symptoms. Therefore, the patient avoids eating a lot of food or patient avoids taking large meals, beta. Hopefully clear to all of you now. So that is what is important to be remembered. No issue still here. These are the points that you have to keep in mind. Clear? Chalo. So do remember, these are the three commonest done surgeries which are done for bariatrics, beta. Okay, BPD with duodenal switch is not done nowadays, but it is the one which was associated with maximum weight loss. It is not done nowadays because it is associated with a lot of malabsorption. That is the reason. Important is if they ask you what is the cutoff. So do remember the cutoff values if I ask you. At which BMI you have to go for a bariatric surgery. So we know we can go for a bariatric surgery at a BMI of more than 40 with or without comorbidities, beta, worldwide. But in Asia, it is basically a BMI of more than 37.5, beta, with or without comorbidities. So worldwide, it is a cutoff of BMI more than 40. In Asia, it is a BMI of more than 37.5, beta. That is what is important. Whereas if I talk about in cases of comorbidities, then you can do the bariatric surgery even if the BMI is more than 35, beta. Even if the BMI is more than 35 and if it is associated with comorbidities or other diseases like diabetes mellitus or osteoarthritis, okay, or obstructive sleep apnea. So in those conditions, you can do a bariatric surgery even at a lower BMI of more than 35. Or in Asia, it is going to be a cutoff of BMI more than 32.5. In Asians, if the patient is having comorbidities or other diseases, then you can do a bariatric surgery even at a BMI of more than 32.5, beta. That is what is important to be remembered. Clear? Chalo. Important is if they ask you about the most common nutrient deficiency. I have told you about three surgeries. Whether they talk about any bariatric surgery or the metabolic surgery, or they even talk about any gastrectomy surgery, or even they talk about the peptic ulcer surgeries like vagotomy or Billroth surgery. So peptic ulcer surgeries like vagotomy or Billroth, or gastrectomy surgeries or bariatric surgery. Please tell me which is going to be the most common nutrient deficiency. Let me know in the chat box. Which are the most common nutrient deficiency in the patient? Let me know in the chat box. ठीक है? Yes, very good. The most common nutrient deficiency in this surgery is going to be iron deficiency, followed by vitamin B12 deficiency, followed by calcium deficiency. Very good. Shabash. So it is going to be iron deficiency, followed by vitamin B12 deficiency, followed by calcium deficiency. So do remember, whenever a patient undergoes three types of surgery, whatever history they give you, bariatric surgery, Peptic ulcer surgery is like vagotomy or Billroth, or the gastrectomy surgery. Most common deficiency is iron, followed by vitamin B12, followed by calcium beta. That is what is important to be remembered. Okay? So these are the important things. Now a PYQ was, a patient has underwent a bariatric surgery. Few days later, the patient comes for a follow-up. When the patient comes for a follow-up, he complains of fatigue, pallor and paresthesias. The patient comes for follow-up and complains of fatigue, pallor and paresthesias beta. Which among the following supplements will help in treating the patient's condition? Let me know in the chat box. Which among the following supplements will help in treating the patient's condition beta? Let me know in the chat box. That was a PYQ. Recently in NEET PG and previously in FMG it has been asked. See, these are the other two types of surgeries. One is basically the SADI-S surgery. Now, SADI-S surgery which is there, yes, it is going to be a single anastomosis for the surgery beta. Now, the SADI-S or the single anastomosis surgery that we do, what we do over here is, we have to do two things together. One is, we have to apply the stapler and we have to resect the part of stomach along the greater curvature. So you have to resect the part of stomach along the greater curvature. So only a small gastric sleeve is going to be left behind beta. Okay? So that the patient's appetite decreases. But after this, after resecting the stomach, second important is you have to take a jejunum beta and you have to directly connect the jejunum to the stomach or the gastric outlet. You will connect the jejunum directly to the stomach or the gastric outlet. Why? So that the food directly goes from stomach to the jejunum. Okay? The food directly goes from the small sleeve of stomach directly into the jejunum beta. It does not pass through the duodenum. Clear? And this limb that is created is known as the biliopancreatic limb, as you are able to see. This is the biliopancreatic limb, also called as the biliopancreatic loop. So do remember, whenever you are going to do two surgeries together, that is, one is definitely the gastrojejunostomy and second is the sleeve gastrectomy together. That is known as the SADI-S surgery. It is only a single anastomosis surgery, again associated with complications, so not done very commonly nowadays. And last one is the duodenal switch. In duodenal switch, again basically what we do, understand, here again we have to do resection of the stomach beta, but after doing resection of the stomach, here we are going to create two anastomoses. So the only difference between SADI-S and duodenal switch is, in the SADI-S we are only going to have one anastomosis, that is gastrojejunostomy, but in duodenal switch you are going to have two anastomoses beta. That is what is important. The first anastomosis that you see is basically between the stomach and the jejunum. Yes, you actually cut the jejunum, pull the jejunum upwards and directly connect it to the stomach, gastric outlet or the pylorus beta. That is the gastrojejunostomy. And second, you are again going to connect your jejunum to the jejunum from where you have cut, or jejunum to the common channel again, and that is known as jejunojejunostomy. So here definitely beta, again this loop that is created is known as your biliopancreatic limb or the biliopancreatic loop beta. Clear? So this is basically your BPD with duodenal switch. This is the biliopancreatic division along with duodenal switch. But the difference between SADI-S and BPD with duodenal switch is, we know in cases of SADI-S there was only one anastomosis, but here in BPD with duodenal switch you are going to have two anastomosis beta. Okay? So that is what is important. Just remember this thing. Very good. The answer to that question was vitamin B12 and not iron beta, because the reason was nothing else but I mentioned paresthesia. Fatigue and pallor are signs and symptoms of anemia, which can be seen due to iron deficiency as well as due to vitamin B12 deficiency. But as soon as I added the third symptom, that was paresthesia, we know the answer had to be vitamin B12 deficiency, because vitamin B12 deficiency causes both. It causes anemia as well as the peripheral neuropathy leading to paresthesias and numbness beta. So the answer, even if iron was there, I would have marked vitamin B12, because peripheral neuropathy was mentioned in the question or paresthesias was mentioned in the question. Hopefully clear? Chalo. Done? Next is question number 7. A lot of people are always confused in shocks. So let's talk about shock properly. A patient has been brought to the casualty in an unconscious state beta following a chest trauma. They are saying he is hemodynamically unstable with a blood pressure of 80 by 50 millimeters of mercury and the pulse rate is 122 beats per minute. On thorough examination, there is a non-pulsatile rise in JVP and there are muffled heart sounds which were noticed. Very, very classical they have talked about. What is the type of shock in this patient? Let me know in the chat box, beta. Let me know in the chat box what is the classical diagnosis. First of all, diagnosis, so we all know. The patient has come to us in the unconscious state. He is hemodynamically unstable. Okay. Why? Because the patient had some kind of chest trauma. And the patient is hemodynamically unstable. That means the BP is 80 by 50 and the pulse rate is 122. Okay, patient is having the two important keywords, non-pulsatile rise in GVP and muffled heart sounds. So you are able to see a very classical triad over here. The first feature of triad is patient is having hypotension or low BP beta. Second feature of triad is patient is having non-pulsatile rise in JVP or congested neck veins. And third feature of the triad is muffled heart sounds or the muffled S1 and S2. So the classical diagnosis is cardiac tamponade. Yes, all of you are right. It is a classical diagnosis of cardiac tamponade beta. Right? And I hope all of you are quite aware. What is this triad seen in patients of cardiac tamponade called as? So we all know the triad which has been mentioned in the question. It is the classical Beck's triad. We all know the Beck's triad is nothing else but hypotension, congested neck veins or non-pulsatile rise in JVP, and the classical muffled heart sounds. So this is the Beck's triad which is seen in patients suffering from cardiac tamponade. And cardiac tamponade is nothing else but a condition where due to a penetrating trauma to the chest beta, due to a penetrating trauma to the chest, what happens? A lot of blood collects around the heart. And when excess blood collects around the heart in the pericardial cavity or in the pericardial space, there is excess pressure on the heart, and due to that the heart chambers will get collapsed. Okay? As there is penetrating trauma to the chest beta, there is excess bleeding in the pericardial cavity that causes excess blood collection in the pericardial cavity, and that leads to excess pericardial pressure. Due to that excessive pericardial pressure beta, the heart chambers are collapsed, and as the heart chambers are collapsed, we know the heart is not able to relax, so therefore it cannot receive blood. That means there will be less venous return, less cardiac output, and less BP, causing hypotension. Second, as the heart chambers are compressed, they are not able to receive the blood. So all the blood pools up in the neck veins, causing congested neck veins or non-pulsatile rise in JVP. And third important feature, as there is a lot of blood around the heart, you're not able to clearly hear the heart sounds. So there are muffled heart sounds but are inaudible heart sounds. So we know it is a classical diagnosis of nothing else but the classical cardiac tamponade. Clear? Because Beck's triad was seen. Clear? In cases of cardiac tamponade, I have told you always one thing, that the first line investigation in patients of cardiac tamponade is nothing else but the fast or the focused assessment by sonography in trauma. Whenever a patient of cardiac tamponade comes to you, the first investigation is a fast. In fast also beta, the first place where I keep the ultrasound probe is the subxiphoid space to look for any blood collection around the heart or to rule out cardiac tamponade. Investigation of choice if they ask you. So do remember the investigation of choice has to be a 2D echo or a 2D echocardiography. Because on that 2D echocardiography, I can see that there is excess blood collection in the pericardial cavity or excess intrapericardial pressure, due to which the heart chambers are completely collapsed beta. And the treatment is going to be anybody, emergency. What we have to go for? Now, if they ask you a patient has come to you with cardiac tamponade, you are going to answer the question. If a patient comes to you with cardiac tamponade beta, then please tell me what is going to be your answer. What should be your first line treatment? Options are, one is going to be pericardiocentesis, second is thoracotomy. Let me know in the chat box what is going to be your answer. One is going to be pericardiocentesis and second is going to be thoracotomy. What is going to be your answer? Thoracotomy, very good. So we have to go for an emergency thoracotomy. I have told you very clearly that Bailey and Love clearly writes one thing beta, that whenever a patient is having a traumatic cardiac tamponade, in traumatic cardiac tamponade beta, you directly go for emergency thoracotomy or surgery. And by doing a thoracotomy, you are actually going to drain all the blood which is collected around the heart or in the pericardial cavity. I've always told you the first line management or the best line management is always an emergency thoracotomy for a case of traumatic cardiac tamponade. Nowadays, Billy clearly writes that pericardiocentesis has no role in the treatment of traumatic cardiac tamponade. Yes, pericardiocentesis you might have learned in medicine. That's absolutely right. So pericardiocentesis can definitely be done for a case of massive pericardial effusion or for a cardiac tamponade, but which is non-traumatic. So non-traumatic cases में we can go for pericardiocentesis. Traumatic cases directly go for emergency thoracotomy. Whether first line, best line, कुछ भी पूछे, answer is thoracotomy. Clear? Great. Now let's talk about the types of shock. We all know one thing about shock, that shock का best definition will be hypoxia at the cellular level. I have always told you beta that don't say low BP shock or low cardiac output is shock, because there is a type of shock where the patient's cardiac output or the BP can be normal? Which is the type of shock where the patient's cardiac output or BP is normal? Let me know in the chat box. So hypoxia at cellular level is the best definition of shock. When the cells are not able to receive enough amount of oxygen beta. That is what is shock. Clear? So here if I talk about first of all hypovolemic shock. So we all know hypovolemic shock means what? Whenever there is going to be massive blood loss from the body or massive hemorrhage from the body, then definitely the volume of blood in body is going to decrease, and that is known as hypovolemic shock. We all know the most common type of shock is definitely this hypovolemic or hemorrhagic shock itself. We know in this what will happen one by one. Let's see. As there is massive blood loss from the body, the patient's systolic blood pressure is going to decrease, and as systolic blood pressure decreases beta, to increase that systolic BP or for compensation, the pulse rate is going to decrease beta. Clear about that is important. So do remember in this condition, in cases of hypovolemic shock or in cases of hypovolemic shock or in cases of hemorrhagic shock beta, as the patient has massive blood loss from the body, therefore the cardiac output will decrease, due to which the systolic BP will decrease. As the systolic BP is low, to increase that we have to increase the pulse rate beta. There will be a reflex tachycardia. And do remember, as there is low BP in the body, so therefore for compensation, the peripheral vessels will get constricted, and that will increase the peripheral vascular resistance beta. And we know in this patients of hypovolemic shock, as there is less amount of blood or less volume of blood in the body, obviously the neck veins will also have less blood beta, and therefore the JVP of the patient is going to decrease. Hopefully clear. And we know the cause is nothing else but hemorrhage or bleeding. Next is cardiogenic shock beta. If I talk about cardiogenic shock, so do remember, cardiogenic shock is nothing else but due to pump failure. When the heart is not able to pump properly beta, like in patients of CHF or congestive heart failure, as the heart cannot pump properly, that is known as cardiogenic shock. So if I talk about this case beta, whenever the heart cannot pump only beta, obviously it is not able to push the blood out, and therefore the patient has a very low cardiac output. Along with that, as there is low cardiac output, there will be a low systolic BP. And as there is less systolic BP beta, obviously the patient's peripheral vascular resistance is going to be high, because if there is low systolic BP, the peripheral vessels are going to constrict, and therefore the peripheral vascular resistance will be high. Do remember here, the heart is not able to pump the blood. As heart is not able to pump the blood, all the blood is pooling up in the inferior and the superior vena cava. As the blood pools up in the heart and then in the inferior and superior vena cava, ultimately the blood starts pooling up inside the neck veins beta, and therefore the patient will have a rise in jugular venous pressure or rise in JVP. This is nothing else but a case of CHF or a congestive heart failure. Okay, so congestive heart failure mein the patient has cardiogenic shock. Pulse rate of the patient in cardiogenic shock can be high or can be low. Why do I say that? If it is due to congestive heart failure, then the patient's pulse rate will be low. But if in case it is due to tachyarrhythmia, then the patient's pulse rate will be high. How tachyarrhythmia can cause cardiogenic shock? If the patient is having tachyarrhythmia and the heart is beating very, very fast beta. The heart is beating fast, but the problem is it is not relaxing only. As the heart is not able to properly relax, it cannot receive blood. And if it cannot receive the blood, that means venous return is very less. Therefore, cardiac output will be very less, and therefore systolic BP will be very less. So that is going to cause a shock beta. So do remember, if it is due to CHF, low pulse rate, but if it is due to tachyarrhythmia, then high pulse rate will be there. Hopefully clear. That is important. Next important, if I talk about, is an obstructive shock. If I talk about an obstructive shock beta, do remember few things. In cases of obstructive shock, the cause can be cardiac tamponade, tension pneumothorax, pulmonary embolism, some kind of obstruction in the body. So obstructive shock which is there, it is due to cardiac tamponade, tension pneumothorax or pulmonary embolism. Here what happens? There is obstruction to the flow of blood, or there is obstruction to the blood circulation. The blood is not able to properly flow inside the body. That is an obstructive shock. What will happen in obstructive shock? Let's say, we know beta one thing, as the blood is not able to flow in the body, or there is an obstruction, we know the patient's cardiac output is going to decrease. Let's take an example of cardiac tamponade. We know cardiac tamponade mein the heart chambers are collapsed. That's the reason it is neither able to receive the blood nor able to pump the blood. That's the reason the patient will have low cardiac output. And if there is low cardiac output, there will be low systolic BP. Now, the patient is having low systolic BP beta, but do remember here the peripheral vascular resistance which is there. It may be high, it may be low. It depends on the causes beta. Various causes has various things, but do remember peripheral vascular resistance in obstructive shock may be high, may be low beta. Clear? Apart from that, the patient's jugular venous pressure is high. Why? Because we know here the heart chambers are collapsed, I've told you. And as the heart chambers are collapsed, the heart cannot receive the blood. So all the blood collects in the superior vena cava and therefore in the neck veins, causing congested neck veins or non-pulsatile rise in JVP. And here if you see, as the patient's systolic BP is low, we are trying to increase the BP by increasing the pulse rate or increasing the heart rate. Clear? Next is a case of neurogenic shock, classical and the Sarkari shock we know. It is the only exception I hope all of you are quite aware about. Neurogenic shock which is there. Here there is damage to the thoracolumbar spine. As the thoracolumbar spine gets damaged, beta, we know there is decreased sympathetic outflow. If there is decreased sympathetic outflow, the patient's heart rate or pulse rate is going to decrease. And therefore the patient's cardiac output is going to decrease. And patient's blood pressure is going to decrease. So do remember the only type of shock where the patient is going to have an hypotension along with bradycardia is neurogenic shock. Otherwise, in most of the other shocks, you will always find the patient's heart rate or the patient's pulse rate is high. Okay, so bradycardia along with hypotension is a feature of neurogenic shock. We know in this patients of neurogenic shock, beta, as there is decreased sympathetic outflow, what will happen? All the peripheral vessels of the body will get dilated. As all the peripheral vessels of the body are dilated, beta, that's the reason you can find the peripheral vascular resistance is going to decrease, beta. Okay, the PVR or the peripheral vascular resistance decreases. And now, as the peripheral vessels are dilated, all the blood is distributed in the periphery. As all the blood gets distributed in the periphery, beta, the blood is not able to come back to the heart. If the blood is not coming back to the heart, that means there is decreased venous return. If there is decreased venous return, obviously there is no blood in the neck veins also. That's the reason, beta, the patient will have decreased JVP or a collapsed neck veins as well. Clear? So that is what is important. And the cause is usually a trauma. Next important is anaphylactic shock. If I talk about an anaphylactic shock, do remember in anaphylactic shock what is going to happen? There will be some kind of allergy or anaphylaxis in the body. That is a type 1 hypersensitivity. They will give you either a history of bee sting in the patient or they'll give you usually a history of allergic seafood, right? So the patient has consumed some allergic food, beta, or the patient has basically had a bee sting. After which, within few hours, the patient has severe respiratory distress due to laryngeal edema, patient has angioedema or swelling of lips, and the patient's blood pressure suddenly falls or the patient goes in shock. So respiratory distress, angioedema and shock. Think about anaphylactic shock as the answer, beta. In this condition, what is going to happen? Understand one thing. Here we know, beta, as there is a release of histamine, we all know one thing, that histamine is a chemical mediator which is known to cause bronchoconstriction, causing respiratory distress, and vasodilation. As the vessels will get dilated, again, all the blood gets distributed in the periphery. As all the blood is getting distributed in the periphery, we know, beta, the blood is not coming back to the heart. Again, as blood is not coming back to the heart, beta, the venous return is going to be decreased. If venous return is decreased, obviously the cardiac output and the blood pressure is also decreased. As the cardiac output and the systolic BP is going to be decreased, beta, we all know what will happen. The body will try to compensate or the body will try to increase the heart rate. And that is the reason why patient will have increased heart rate or increased pulse rate. That is reflex tachycardia will be there. And do remember here, as all the peripheral vessels are dilated due to histamine, we know that as the peripheral vessels are dilated, therefore the PVR or the peripheral vascular resistance is going to be low. As the blood is not coming back to the heart, there is less blood in the neck veins, beta. Therefore, the patient JVP or the jugular venous pressure will also be low. So do remember everything else in neurogenic shock and in cases of anaphylactic shock is exactly the same because both are examples of distributive shock, beta. The only difference is going to be the history. Anaphylactic shock can be due to some allergic reaction in the body. Neurogenic shock is due to trauma. And another difference is neurogenic shock is going to have bradycardia, whereas anaphylactic shock is going to have reflex tachycardia. The only difference between the two is the pulse rate or the heart rate of the patient. Clear about? Last one is the septic shock. If I talk about septic shock, we all know there are two phases of septic shock. The initial phase is warm septic shock and the latter phase is cold septic shock. In warm septic shock, there is going to be increase in the sympathetic activity of the body. Okay. Whereas in cold septic shock, there will be vasodilation in the body. First of all, if they ask you, in patients of septic shock, beta, in the warm septic shock, the patient's cardiac output will be slightly high due to the increased sympathetic activity. And that's the reason the patient's systolic BP will also be normal or slightly high. But in the latter phases of cold septic shock, beta, okay, when there is release of histamine and there is a peripheral vasodilation, all the blood gets distributed in the periphery and it is not able to return back to the heart, again causing a decreased venous return and a decreased cardiac output. And as there is decreased cardiac output, there will be decreased systolic BP as well. So in cases of septic shock, initially the cardiac output and the systolic BP are high, but later on the cardiac output and systolic BP are low. And we know the patient's heart rate is going to be high in both the types of septic shock, whether it is warm septic shock or cold septic shock. Why? In warm septic shock, as there was increased sympathetic activity in the body, obviously the heart rate was high beta or pulse rate was high. In cold septic shock, as the patient's blood pressure starts falling beta, we know to increase that blood pressure or for compensation, the heart starts beating faster and there is a compensatory reflex tachycardia which is seen. Clear? Next important, we know as there is going to be release of histamine and there is a peripheral vasodilation beta. You will find that all the peripheral vessels are dilated and therefore the peripheral vascular resistance is going to be low. And if you see the JVP or the jugular venous pressure of the patient is also low. And this septic shock is usually due to some severe infection or sepsis. Do you remember neurogenic shock, anaphylactic shock and septic shock? These three are basically an example of nothing else but distributive shock beta. These three are going to be an example of nothing else but the distributive shock. Hopefully clear. So that is what is important. So yaad rakhna, obstructive shock is due to problems like cardiac tamponade, tension pneumothorax and pulmonary embolism, whereas distributive shock can be a neurogenic shock, anaphylactic shock or cold septic shock. Hopefully clear. Yes, we all know in distributive shock, the peripheries are going to be warm. Why? Because as the peripheral vessels are dilated and all the blood is distributed in the peripheries are going to be warm to touch in cases of distributive shock beta, whether it is going to be a neurogenic shock, anaphylactic shock or the cold septic shock. Sorry, the warm septic shock. Okay, that is important. If they ask what is the type of shock seen in this patient, we know cardiac tamponade usually causes an obstructive shock. So the answer to this question has to be nothing else but option D. If in case obstructive shock is an option, better answer for cardiac tamponade is always an obstructive shock. I've told you the other causes of obstructive shock apart from cardiac tamponade, it is going to be a tension pneumothorax and pulmonary embolism. Because there is obstruction to the flow of blood in the body. Hopefully clear. We all know hypovolemic shock mein, one thing that you have to remember, in cases of hypovolemic shock, the patient's JVP or jugular venous pressure is actually going to be low beta. Okay, and muffled heart sounds will not be seen. Next important, cardiogenic shock mein, do you remember one thing again, in patients of cardiogenic shock, again basically beta, one thing you have to remember, in case of cardiogenic shock, yes, there is rise in jugular venous pressure that you can see beta, but again muffled heart sounds are not seen in case of cardiogenic shock beta because it is not due to cardiac tamponade, right? Muffled heart sounds can only be seen in cardiac tamponade, which causes an obstructive shock. Clear? If they would have given you the history of CHF or arrhythmias, then my answer would have been cardiogenic shock. Next, distributive shock. Distributive shock means neurogenic, anaphylactic or septic shock. That is a completely different feature beta that you have to remember. In all of them, there is never a rise in JVP, there is always a fall in JVP. As you can see, in all the other types of distributive shock, the jugular venous pressure is always going to be low. It is never high. Hopefully clear hai baat yahan tak? Chalo. Next, move on to the next question. Question number 8, a recent question in the NEET PG beta. And that question was, a 15-year-old girl presents to you with complaints of recurrent urinary tract infections. An ultrasound done has been given below, which reveals there is a dilated ureter and a dilated pelvic calyceal system beta. An IVU or an intravenous urogram was performed and it has been given below. What shall be the most appropriate first line treatment in the patient? First of all, we all know the patient is having recurrent urinary tract infection. What is the reason? The reason for this would have been urine retention. As the patient is not able to pass urine due to that urine retention, patient has recurrent UTI. Next, there is dilated ureter and a dilated pelvic calyceal system. That means the patient is going to have hydroureteronephrosis beta, or you can say the patient is having hydroureter as well as hydronephrosis. Barabar na? Dilated ureter is hydroureter, dilated pelvic calyceal system is hydronephrosis. So the patient is having hydroureteronephrosis, and this hydroureteronephrosis only develops whenever there is a urine retention in the patient's body. Whenever there is a severe urine retention in the patient's body, that causes this hydroureteronephrosis. Let's see what is seen on the IVU or an intravenous urogram. Sarkari picture. The intravenous urogram shows you the classical appearance. What is this appearance called as? Let me know in the chat box. This appearance that is seen on the IVU or the intravenous urogram, that is classically known as the Sarkari repeated question of FMG examination nowadays. What is seen over here? We know the classical appearance. Yes, very good. That was a recent question of the FMG examination in Jan. You are able to see the classical cobra head appearance or the adder head appearance, right? Very good. So that is a classical cobra head or an adder head appearance that you are able to see on the intravenous urogram. And we know one thing for sure, that whenever a cobra head or an adder head appearance is seen on the IVU, it is a classical diagnosis of, all of you know this condition now, it is a Sarkari case of nothing else but ureterocele. And we know in case of ureterocele, what is the problem? Ureterocele mein the intramural portion or the intravesical portion of the ureter is dilated. Why the intramural or the intravesical portion of the ureter is dilated? Because the ureteric opening or the ureteric orifice in the bladder is very, very narrow. As the ureteric opening is very narrow, beta, okay, that is the reason why the ureter is not able to drain properly, causing dilatation of the intramural ureter called as ureterocele. Clear? And that gives that cobra head or adder head appearance. And as the ureteric opening is very narrow, beta, that's the reason the patient cannot drain the urine properly from ureter to the bladder, causing urine retention or hydroureteronephrosis. You can see there is dilatation of the ureters as well as dilatation of the pelvis. So it is a hydroureteronephrosis which is seen. So we know ureterocele is basically due to the partial atresia of the ureteric orifice. That means whenever the ureteric orifice or the ureteric opening is not properly formed or it is not completely formed, that partial atresia of the ureteric orifice is the reason for ureterocele. Hopefully clear to all of you now. So that is what is important. If they ask you what is the treatment, so do remember in this condition the treatment is nothing else but option C, that is an ureteric reimplantation, beta. The treatment in this condition is nothing else but an ureteric reimplantation. Now we have also one more option, beta, and that is we can make an incision and we can widen the ureteric opening. Okay, you can make an incision and widen the ureteric opening, but the problem with that is nothing else but basically, beta. Okay, the problem with that, it is nothing else but basically, see, we know if you directly widen the ureteric opening, what will happen? There will be a high risk of VUR or vesico-ureteric reflux, beta. The patient will have a high risk of VUR or vesico-ureteric reflux. Now, coming back to the question, here it is a case of ureterocele, but they have asked you most appropriate first line treatment, beta. Now, if it is a first line treatment, I have two options which I can use. I miss that first line treatment. I also miss at times. So be aware while you're reading the last line of the question. One option is DJ stent placement, that is double J stent can be placed, beta. If you place a double J stent, then the ureter will be able to drain properly, beta. So for a few days, you can do a DJ stent or a double J stent placement or a cysto-ureteroscope. And another option is ureteric reimplantation. Now we all know ureteric reimplantation is the best treatment or it is the definitive treatment, beta. But is it the first line treatment? No, because now basically we just want, beta, the urine to be drained which has been retained inside the ureter and the pelvis. So that's the reason the first line treatment, if they ask me, answer is nothing else but, beta, we can either go for DJ stent placement. One more thing I can do as a first line is cystoscopic dilatation. That is, we have to go inside the urinary bladder, and after doing a cystoscopy we have to dilate the ureter, beta. Now we have two options for first line treatment. One is a cystoscopic dilatation and second is a DJ stent placement. Now here if you ask me that what will be a preferred answer, my answer would be option A, that is nothing else but cystoscopic dilatation, beta. We will just do a cystoscopy and try to dilate the ureteric opening. If I dilate and widen the ureteric opening, most of the time, beta, the patient's problem gets resolved. In case if the patient's problem is not resolved, then I can go for option C, that is the ureteric reimplantation. Clear? DJ stent placement can be done for a ureterocele, but the problem is that DJ stent placement which is there, it is usually done whenever there is an obstruction in the urine flow in the ureter or there is ureteric strictures. So if they would have said that the patient is actually having ureteric strictures, then my better answer would have been a DJ stent placement or a double J stent placement. But here they are not saying any kind of strictures. Okay? Here they are not talking about any kind of strictures. That's the reason, again, DJ stent placement will be a secondary answer to this. So do remember, definitely in this condition, my better answer to that question will be option A, cystoscopic dilatation. Reason is because they have asked first line treatment. If the question was about the best or the most definitive treatment, my answer would have been option C, ureteric reimplantation. Clear? We have discussed already that ureterostomy is always done basically beta, that whenever the ureteric length is very short, ureter's length is very short beta. So whenever there is a short ureter, okay, in those conditions we have to go for a ureterostomy. What do I mean by this? So do remember, whenever there is an excessively short ureter beta, okay, any reason, maybe the ureter was damaged during the surgery, or the ureter was damaged due to trauma, or the ureter has not formed only properly. Okay, so in those conditions, what we do, if the ureter is very short, what I do is, we basically connect one ureter to the opposite sided ureter beta. Yes, we have to connect. Let's say this ureter is very short. Now you can see this ureter is very short. Therefore, I cannot connect it to the bladder. Neither I can create a flap. If there was a short segment which was missing beta, only a small segment of ureter was missing, I would have created a flap beta called as the Boris flap. But here, as a very long segment of the ureter is missing, or the ureter is extremely short, what I do is, we better connect that ureter to the opposite sided ureter. I've told this to you. We better connect the ureter to the opposite sided ureter, and that is classically known as the ureterostomy. So what is going to happen in this surgery? Both the kidneys are actually going to drain via the single ureter now. Both the kidneys are going to actually drain via the single ureter. Hopefully clear to all of you now. So that is what is important to be remembered. Understood? So whenever there is a very short ureter and you are not able to create a flap, then you can just open or connect the ureter to the opposite one. That is known as ureterostomy or a ureteric anastomosis. Clear? This is a previous year image based question. This is nothing else but a DJ stent or a double J stent, also called as a cystoureteroscope beta. This is the classical DJ stent, also called as a double J stent, also known as a cystoureteroscope. And do remember, this is usually used whenever there is blockage in the flow of urine, or whenever there is a ureteric stricture which is formed. In those conditions, to open up the ureter and to drain the urine properly, we have to insert the DJ stent or the cystoureteroscope. Hopefully clear? Chalo. Next important if I talk about is question number 9 beta. It states, we are having a middle-aged patient who came to the hospital with complaints of long-standing lumbar pain which is radiating to the scrotum of the patient. He also had a history of UTIs or urinary tract infections in the past, and further workup reveals there is a ureteric calculi measuring around 7 millimeters in size. They are asking you what shall be the definitive management in the patient. They are asking you what shall be the definitive management of the patient. So please tell me beta, what is going to be your definitive management? Let me know in the chat box. It is a ureteric stone or a ureteric calculi, and they're asking you what is the management. So I hope all of you are quite aware that whenever the stone is usually in the ureter, the patient is not only going to have lumbar pain, but the patient will have that lumbar pain which radiates to various sides. So lumbar pain radiating to the scrotum, perineum, iliac fossa or the labia beta. That is basically a sign of stone inside the ureter, ureteric calculi. Okay? And due to the obstruction to the flow of urine, patient might be having urine retention causing UTIs as well. And here they are saying the ureteric calculi is measuring around 7 millimeters in size. So I have always told you what is the management for a case of ureteric calculi. So whenever there is a ureteric calculi or a ureteric stone, whenever it is less than 5 to 6 mm in size, okay, and not causing any obstruction, that means it is not impacted. Whenever the ureteric calculi is less than 5 to 6 mm in size and it is not impacted beta, non-impacted, not causing any obstruction as such, then in those conditions you just have to go for an observation, or you have to just go for a conservative management. That is, advise to take plenty of fluids, give painkillers or analgesics, and you can give urine alkalizers beta, right? Yes, the observation or conservative management has to be done. But in case if the stone size is more than 5 to 6 millimeter beta, or definitely the patient is having a impacted stone, even if the size is small, but if the stone is impacted, or if the stone is causing an obstruction somewhere or urine retention, so if there is a more than 5 to 6 mm stone or it is an impacted stone, we have to go for removal of stone, and that is nothing else but a ureteric calculi beta. Sorry, ureteroscopic removal of stone, URS basically. You have to go for a URS, that is nothing else but ureteroscopic removal of stone. Done with the help of which basket, anybody? We all know whenever we have to remove stone from the ureter, that ureteroscopic removal of stone has to be done with the help of a special basket called as the Dormia basket, right? So we have to do a ureteroscopic removal of stone with the help of a Dormia basket. Ureteroscopic removal of stone has to be done along with Dormia basket. Hopefully clear. So that is what is important to be remembered. Yes, PCNL is mostly done for a renal stone or a stone which is usually inside, nothing else but beta the pelvis region. Hopefully clear. So that is what is important. You are feeling that you have forgotten everything just because you're too anxious and too nervous. Try to just curb down your anxiety. You are going to remember everything once you see the questions in the examination. Clear? So just try to be calm and composed while you're attempting the questions in the examination. Otherwise, you have read everything. You don't have to be too much anxious about anything. Clear? So that is important. Okay. You can also use an ESWL. When is ESWL used? We know ESWL can be used beta for a stone which is non-impacted. If there is a large stone, that is a stone which is more than 5 to 6 millimeters in size beta, and it is non-impacted, that means it is not impacted or not obstructed somewhere. In those conditions, I can try for an ESWL or an extracorporeal shock wave lithotripsy. In extracorporeal shock wave lithotripsy beta, we know we have to just break down the stone into small pieces by ESWL. And once you have broken down the stone into small pieces or small fragments, along with the urine, the pieces of the stones will get excreted out. That is ESWL. Clear? As the stone was 7 millimeter and it was also causing retention of urine leading to UTIs again and again. The definitive management over here, we all know beta, has to be extraction of the stone or a ureteroscopic removal of the stone along with Dormia basket, that is URS. Ureteroscopic removal of the stone has to be done. Clear? That is important. Option C says percutaneous nephrolithotomy. PCNL is never done for a ureteric calculi or a ureteric stone. It is usually done for a stone inside the kidneys or the renal pelvis beta. Extracorporeal shock wave lithotripsy or ESWL, I have told you, it is usually done for a large stone which is more than 5 to 6 mm in size, but condition being it is non-impacted. And here by this, patient is having lumbar pain radiating to the scrotum and there is history of UTI. That can be due to urine retention. These are the signs that it seems to be a impacted stone beta. And that's the reason ESWL will not be a preferred option over here. Clear? Analgesics and plenty of fluids, yes, they are to be given in the patient. As the patient is having stones, you have to give analgesics and plenty of fluids. But they have not asked you about the first line management or an adjuvant management. They have asked you about the definitive management. And the definitive management will be URS or extraction of stone with the help of Dormia basket beta. Mostly ureteroscopic removal is preferred. You can also go for ESWL as I've told you in some conditions. But for ESWL, do remember that the stone should not be impacted or the stone should not be obstructed somewhere beta. If it is an impacted stone, then even if you break down the stone with ESWL, it will be very difficult beta for the stone pieces to come out. Okay? So that is important. So now these are the pictures that you can see. First of all, whenever you fire shock waves onto the stone beta and then the stone is broken down into small pieces or small fragments and then it gets excreted out with the urine. This is known as ESWL, that is extracorporeal shock wave lithotripsy. We all know ESWL can be done for the renal stones as well as for ureteric stones beta. Okay, so it can be done for renal stones or ureteric stones. For which kind of renal stones it can be done? For ureteric stones, I have told you, it can be done for stones which are larger than more than 5 to 6 mm but which are not impacted. And renal stones ke liye it can be done whenever the size of stone is more than 5 to 6 mm. Renal stone ke liye it can be done whenever the size of stone is more than 5 to 6 mm. Do remember some important thing, that ESWL will be absolutely contraindicated beta whenever the size of the stone is going to be more than 2 centimeters, or it is also contraindicated when definitely the patient is pregnant. If the female is pregnant beta, then ESWL or firing shockwave is not an advisable option. It is also going to be contraindicated whenever there is going to be some kind of distal obstruction beta. Whenever there is some kind of distal obstruction or obstruction in the urethra of the patient, then also it is going to be contraindicated as well. Okay, it is also going to be contraindicated. Do remember that whenever the patient is actually having a hard stone like a cystine stone, okay, or even contraindicated when patient is having bleeding disorders. So do remember these are few contraindications where doing a ESWL is not commonly preferred. Doing an ESWL is not commonly preferred in these kind of conditions beta, has to be remembered. And ESWL, if it cannot be done, you can go for PCNL, right? We can go for PCNL or a percutaneous nephrolithotomy beta. Clear? So that is what is important to be remembered. Understood? And we know in cases of ESWL, once you have broken down the stone, then the stone pieces align themselves in the ureter so that they can get excreted out in urine. So in the ureter, you are able to see a line of stones or street of stones, and that is classically called as the Sten-Strass phenomena. So Sten-Strass phenomena is nothing else but the line of stones or street of stones that you are able to see. This was an important question which has been asked in the PYQ. So if you are able to see a street of stones in the ureter, that is Sten-Strass phenomenon that was asked, that this will be a finding seen after which procedure. So this will be a finding seen after ESWL or extracorporeal shock wave lithotripsy. Clear? Next, if you are directly inserting a nephroscope beta and directly removing the stones from the kidney, that means definitely it is a procedure called as PCNL, also called as percutaneous nephrolithotomy. This is a picture of nothing else but PCNL, and we all know PCNL can be done for all the renal stones beta. PCNL can be done for renal stones. Condition being what? Condition being that the stone is usually more than 2 centimeters in size, or if there is any kind of distal obstruction. So you can say in whichever condition the ESWL is contraindicated, in all those conditions you can definitely go for PCNL in the patient, especially for a stone more than 2 centimeters in size, because that cannot be removed via ureter also, that you have to always remove via the lumbar area itself from the PCNL procedure. And second, if there is a distal obstruction, again, if there is an obstruction in the urethra, you cannot remove stone via urethra, you have to again remove it directly percutaneously beta. Clear? Next, this is nothing else but the picture of URS that we have already discussed. This is ureteroscopic removal of stone, where you can see a ureteroscope that we have inserted, and this is the classical Domia basket beta, which is going to entrap the stone, and then we are going to pull back the stone which has been entrapped inside this Dormia basket. Hopefully clear. That is important. Question number 10. Now they are asking you, they are saying we are having a 5-month-old baby who has been brought to your OPD with complaints of bilaterally undescended testes. They are asking you what shall be the most appropriate treatment approach in this case. So what should be your most appropriate treatment approach in this case? A lot of people were confused with this question because the options were changing. So I thought to pick up this question and tell you what is basically the answer with some different kind of options which may appear in the exam. Now please tell me, what do you think? Option A says it is an immediate orchidopexy. Option B says wait and watch for spontaneous descent till 1 year of age. Option C says GnRH analogs and surgery if needed. Option D says surgical exploration. Now we all know the diagnosis has been given clearly that the child is 5-month-old baby and he is having an bilaterally undescended testis. So it is a case of an undescended testis or cryptorchidism. We all have discussed one thing earlier, that whenever there is a diagnosis of cryptorchidism or an undescended testis beta, okay, one thing we have to remember for sure, that means the testis has been arrested inside the normal path of descent. Somewhere in the normal path of descent, the testis has been arrested, or the descent was not able to complete on time, right? That means the testis can be either in the abdomen, or it can be either inside the inguinal canal, or it can be somewhere in the scrotum. Abdomen, inguinal canal and scrotum, if the testis is arrested, that is an undescended testis because it is arrested in the normal path of descent. We know the most common cause of cryptorchidism or undescended testis is idiopathic. Risk factor can be prematurity. Risk factor is prematurity beta. That means if the baby is born before 37 or before 34 weeks period of gestation, we know the descent of testis might not have completed because the normal descent time of testis is 7 to 9 months. If the child is born early, the descent might not be completed, causing undescended testis. Do you remember most commonly undescended testis is seen on the right side, because we know the right-sided testis descends late as compared to the left-sided testis. I've always told you the right-sided testis descends late as compared to the left-sided testis beta. Therefore, right-sided testis right-sided testis is more commonly presenting with undescended testis. Important is the most common site for an undescended testis is inguinal canal. We all know the most common site where the testis gets arrested is basically the inguinal canal, has to be remembered. If they ask you for diagnosis, what is done? So we all know one thing, that if the testis is in the inguinal canal, only an ultrasound is enough to confirm the diagnosis. But if the testis is somewhere else, you have to go for a better investigation, that is a diagnostic laparoscopy. So to confirm the diagnosis of undescended testis or cryptorchidism, initially you go for an ultrasound beta, but later on you have to go for a laparoscopy in the patient. Clear? Now important is if they ask you treatment. So we have discussed always one treatment, and that is whenever a patient of undescended testis is brought to us and the child's age is usually less than 6 months, beta, do we go for any surgery? I've always told you, whenever a child is brought to you before 6 months of age, okay, and there is an undescended testis, we don't go for any surgery. We are just going to do reassurance. You just have to reassure the parents of the baby that the testis will come down spontaneously. They will descend down on their own, beta. Okay, between 6 to 7 months of age. That is what is seen. In majority cases, you are able to see a spontaneous descent of testis, beta. You don't need to go for any surgery. So reassurance, observation, wait and watch, no treatment, conservative management can be done. Or in case if there are bilateral and descended testes, then you can try the injection of GnRH analogs, beta. GnRH analogs are the drugs like nafarelin, goserelin, buserelin, and these GnRH analogs which are there, if they are given in a pulsatile manner, then they are going to cause a stimulation, beta, and they can definitely cause a descent of testis. Clear? So do remember that is what is important to be remembered. Clear? And this, if the child presents to us after 6 months of age, if the child presents to us after 6 months of age, then definitely you can go for surgical exploration. After 6 months of age, beta, it's better that we go for a surgical exploration and we try to find the testis. Once we have done the surgical exploration, okay, then we are able to find the testis. Let's say if the testis gets located, if you are able to find the testis somewhere, or if the testis was located, then you have to bring down the testis and scrotum and fix it, known as an orchidopexy. Then you have to bring down the testis and scrotum and perform an orchidopexy, beta. But if the testis was not located, let's say you are not able to find the testis, beta. Let's say the testis was not located. Millinariae testis. You are doing a surgical exploration, but you cannot find the testis. If the testis is not located, I have told you, then you have to search for testicular vessels. If you are not able to find the testis, beta, then please remember you have to search for the testicular vessels. In case if the testicular vessels are present, in case if they say the testicular vessels are present, that means the testis will also be present, beta. Just continue exploration then. In case if the testicular vessels are present, then definitely we know that the testis will also be present. Just continue your exploration, you will find the testis. But if testicular vessels are itself absent, the testicular vessel or the spermatic cord is absent, there is no use of doing an exploration because the testis has already got vanished. There is no use of finding the testis because the testis has got already vanished, so you can stop the exploration. That is how we decide the management in a case of cryptorchidism or a undescended testis, beta. Hopefully you remember this from your text workbooks. Basically, this is how we have discussed undescended testis ka management, right? Now important is if they ask you, okay? So it will be for some more time, beta. Okay? So now if I talk about here, option A says immediate orchidopexy. No. As my child is only 5 months of age, I don't need an immediate orchidopexy or the fixation of the testis. Now option B says wait and watch for spontaneous descent. Yes, as the child is less than 6 months of age, I can do a wait and watch for spontaneous descent. But they are saying till 1 year of age. Is it true? No. We can wait and watch up to 6 months of age, beta, not up to 1 year of age. That is what is important. Okay? Usually up to 6 months of age, basically we go for wait and watch. Between 6 to 18 months, that is the best time for doing a surgical exploration and orchidopexy. After 6 months, beta, okay, 6 to 18 months is the best time according to Bailey to do a. Okay? So do remember this. Okay? These are total 20 questions basically, beta. The topics are going to be similar. Okay, so that is important. You can see the other PDFs of the questions as well. Now important, if I talk about basically the PDFs that I've shared from the previous sessions, you can find those in my group. You can also go through those PDFs on faster. So do remember that 6 to 18 months is the best time for doing an orchidopexy. Option C says GnRH analogs and surgery if needed. Yes. So we know, beta, that GnRH analogs can be given to the patient in a pulsatile manner. Okay, like goserelin, and surgery if needed. Yes, surgery if needed, but only after 6 months of age. Okay, so therefore this seems to be a more appropriate answer to me. Answer has to be option C for this question. It seems more appropriate than option B because option B says you can wait up to 1 year of age. No, I don't wait up to 1 year of age. I only wait up to 6 months of age, beta. And option C says GnRH analogs. Yes, we can give GnRH analogs even before 6 months of age. And surgery if needed. Yes, surgery if needed, but only after 6 months. Clear? That is important. Option D says surgical exploration. No, surgical exploration is not needed in this patient now. Clear? Next important is question number 11 beta. Now this is not only a question important for surgery but any other surgical subject like obs and gynae also. This question has come earlier in a different manner, but yeah, the answer was same. So here you can see we are having a 72-year-old patient beta who was diagnosed with BPH or benign prostatic hyperplasia and underwent a surgery called as TURP, that is transurethral resection of prostate under spinal anesthesia. They are saying after 1 hour he has developed problems like vomiting and altered sensorium. They are asking you what is the most probable cause for this case. So let me know in the chat box beta. Let me know in the chat box what is the most probable cause for this case. So now understand what I am trying to tell. Let's say the patient has gone for a treatment of BPH. I hope all of you are quite aware about BPH first. BPH is nothing else but benign prostatic hyperplasia. What happens in patients of BPH or benign prostatic hyperplasia? The size of the prostate gland which is there beta, it is going to increase. And as the size of the prostate gland is going to increase, we know it is going to cause compression of the prostatic urethra. It is going to cause compression of the prostatic urethra, and as it is going to cause compression of the prostatic urethra, patient will not be able to pass urine, causing urine retention or the lower urinary tract symptoms beta. That has to be remembered. Clear? Now we all know about one thing about BPH. BPH is going to be commonly seen in patients who are more than 50 years of age or elderly patients. Second, the most common site for BPH is going to be the transitional zone of prostate, right? The most common site for BPH is nothing else but the transitional zone of prostate. BPH is common in the transitional zone, whereas cancer is common in the peripheral zone. So BPH common in transitional zone and prostate cancer common in peripheral zone of the prostate. We know in cases of BPH, the patient comes to us with complaints of LUTS. And what is LUTS? Lower urinary tract symptoms. And LUTS or lower urinary tract symptoms are nothing else but patient is going to have increased frequency of urination, patient is going to have urine retention, patient is going to have nocturia or increased frequency at the night time, patient is going to have difficulty in starting the urination, that is hesitancy, patient will have breaks in urine, that is intermittency, patient will have very poor or a weak stream of urine beta, patli dhar, the patient will have poor stream of urine. Multiple features together are called as LUTS, that is lower urinary tract symptoms. We know investigation of choice to diagnose a case of BPH is nothing else but you have to do a ultrasound beta, you have to do an ultrasound KUBP, and when you do an ultrasound KUBP or kidney ureter prostate, bladder and prostate, on that ultrasound KUBP you will find that the size of prostate is more than 30 cc and the post-void residue is more than 100 cc, right? Size of prostate more than 30 and post-void residue more than 100 cc. Along with that, you have to also do the serum PSA levels. Why? Reason is, see, ultrasound showing an enlarged prostate could be a diagnosis of BPH, could be a diagnosis of prostate cancer, because in both the condition the prostate gland is enlarged. So only ultrasound is not enough. Along with ultrasound, you have to check the serum PSA levels, and in patients of BPH, serum PSA levels are normal or slightly elevated. But if the serum PSA levels are very, very high, that could be a diagnosis of prostate cancer beta. If the serum PSA levels are very, very high, it could be a diagnosis of prostate cancer in the patient. And treatment, we all know the drug of choice in patients of BPH initially is tamsulosin. We all know tamsulosin or silodosin are the selective alpha-1A blockers. They are going to dilate the prostatic urethra and they will increase the patient's urinary flow. So tamsulosin is a selective alpha-1A blocker, which is the drug of choice. Along with that, you have to give another drug to decrease the size of prostate, that is known as finasteride. We all know finasteride is a 5-alpha reductase inhibitor, and this finasteride or 5-alpha reductase inhibitor is the drug which will help in decreasing the size of prostate gland beta. Clear? So that is what is important. Apart from that, we know if the patient is having BPH along with hypertension, do remember the drug of choice has to be prazosin, which is an alpha-1 blocker. BPH along with hypertension में the drug of choice has to be prazosin, which is an alpha-1 blocker. Don't make that mistake. And if the patient is not responding to medical therapy, then we go for TURP. If the patient is not responding to medical therapy, then we go for TURP. Now understand, the patient has already undergone a TURP surgery beta, and after that he is experiencing some complication. What is that complication? Just remember one thing. Here you can see that while you are doing a TURP surgery and there is an enlarged prostate that you are trying to remove or that you are trying to resect in size, what will happen? See, we know during surgeries beta, during resection surgeries, we tend to use fluid. In case the fluid that you have used was a hypotonic fluid, Hypotonic matlab the fluid that has less concentration as compared to blood or less concentration as compared to plasma. Like if you're using half normal saline, or you're using 5% dextrose, or you're only using distilled water. So hypotonic fluid, something like 5% dextrose, half normal saline, distilled water. Then this problem is going to arise. Why? As you're using hypotonic fluid, beta, we all know the patient's concentration at the surgical site is less. Hypotonic fluid की वजह से the concentration at the surgical site is less. But comparatively, if you compare, the concentration inside the blood vessel is high. The concentration inside the blood vessel is more. Therefore, what will happen? Body will always try to equalize concentration on both the sides. As body wants to equalize the concentration on both the sides, a lot of fluid gets absorbed inside the blood vessel. A lot of fluid or a lot of water gets absorbed inside the blood vessel. Why? Because we want to bring down the concentration of the blood, or we have to equalize concentration on both the sides. So body absorbs a lot of fluid inside the blood vessel. And when body absorbs a lot of fluid in the blood vessel, the blood or the plasma gets diluted. And if the blood or the plasma gets diluted, what will happen? Understand. As a lot of water or fluid was absorbed, the total body water will increase in the blood, but the total sodium levels remain the same. Okay, the total sodium levels remain the same, but the total body water increases. And due to this, it seems as if there are low sodium levels, or as if there is a hyponatremia. So due to that excess water in the blood, it seems the patient is having a dilutional hyponatremia or a relative hyponatremia. And due to this dilutional or the relative hyponatremia, beta, the patient is going to have symptoms like nausea, vomiting, altered sensorium, okay, confusion, even seizures if there is a severe hyponatremia after surgery. So after this surgery, beta, if the patient is having dilutional hyponatremia like symptoms, nausea, vomiting, altered sensorium, confusion and seizures, we know the diagnosis is nothing else but a case called as water intoxication syndrome, also called as TERP syndrome, beta. Okay, a lot of water was absorbed inside the blood vessels now. Therefore, there was intoxication of water, you can say. That is known as the water intoxication syndrome, also called as TERP syndrome. Hopefully clear. So that is important. Now, what should have been done to treat this? If the patient develops a water intoxication syndrome, treatment is nothing else but fluid restriction. Why? Because a lot of fluid has already got absorbed inside the blood vessel. As a lot of fluid has already got absorbed in the blood vessel, don't give more fluid to the patient, do a fluid restriction or stop giving fluid. And second important beta, if there is a severe hyponatremia, in those conditions, you have to give sodium from outside, and that is IV 3% hypotonic saline. If there is a severe hyponatremia, then you have to give sodium from outside, that is IV 3% hypotonic saline has to be given. Now, what should be done if you want to prevent this problem of water intoxication syndrome or TERP syndrome? If you don't want this problem to happen, that is water intoxication or TERP syndrome, beta, we know better is use an isotonic fluid for irrigation. So during the surgery for irrigation, use an isotonic fluid called as isotonic glycine. Use an isotonic fluid like isotonic glycine for irrigation, beta, for prevention. If you don't want this problem to develop, do remember use isotonic glycine for prevention. Hopefully clear. Now, so here if they say as the patient has undergone the TERP surgery and then he develops nausea, vomiting, altered sensorium. So we know it is a classical case of nothing else but water intoxication syndrome or TERP syndrome. Answer has to be option B. It is not a relative hypernatremia, beta. It is a relative hyponatremia. Because of diluted blood, the patient will have relative hyponatremia, not hyper. Rupture of urethra, no. Rupture of urethra can cause sudden syncope or sudden shock in the patient. That may happen. Overdose of anesthesia, again, overdose of anesthesia may, the patient will not come out of the anesthesia, beta. The patient might be sedated for too long, or the patient might have risk of shock as well. But not these features of water intoxication. Hopefully clear. So that is what is important. Chalo, clear hai baat? So that was a case. Next important is question number 12. Another easy question it is. You were posted in surgery department and while taking the rounds, beta, you notice the patient having the given finding while taking the blood pressure of this patient, and she complains of numbness as well as paresthesias, beta. She underwent a total thyroidectomy for a medullary thyroid carcinoma 2 days prior. So she is having a history of total thyroidectomy. The most likely cause for this condition is. Now you can see the question. Please try to answer the question in the chat box. This has been a repeated question in the FMJ exam. Either they ask about nerve injury or this complication after the total thyroidectomy surgery. Both will discuss. Let me know what do you think. Clear? So here we know beta that this sign that you are able to see in the picture, this sign is classically called as the Trousseau sign. Right? This sign is classically called as the Trousseau sign beta, also called as the carpopedal spasm. And it is a sign of which electrolyte disturbance? Let me know in the chat box. This sign is called as the Trousseau sign, which is also called as the carpopedal spasm. हाथ पैर टेढ़े हो जाते पेशेंट के, या फिर it is also called as the obstetrician's hands. The Trousseau sign, carpopedal spasm, obstetrician's hands which are there. These are the classical features that you can see in the patient. Okay? This is not the Chvostek sign. Chvostek sign is different. Chvostek sign means when you tap along the facial nerve, patient will have facial grimacing or odd facial expressions like this. That is basically called as the Trousseau sign beta. So that is called as the Chvostek sign beta or the facial grimacing. But this is the Trousseau sign or the carpopedal spasm. जब हाथ पैर टेढ़े हो जाते हैं. Yes, very good. This is a classical sign of hypocalcemia in the patient, right? This is definitely a sign of nothing else but hypocalcemia. So we all know the Trousseau sign called as carpopedal spasm or the Chvostek sign known as facial grimacing. Both of these are the classical signs of hypocalcemia in the patient. So they are saying that the patient has undergone total thyroidectomy 2 days prior, and now the patient is having the signs and symptoms of hypocalcemia. How? The patient is definitely having numbness and paresthesias beta. So we know whenever the patient will have perioral numbness or perioral paresthesias or numbness or paresthesias in tip of fingers, that is a very classical sign of hypocalcemia again. Clear? Why the hell patient is having hypocalcemia? There might be two reasons beta. Either we have accidentally removed the parathyroid gland. We know while you remove the thyroid gland, sometimes there can be an accidental removal of the parathyroid gland also beta, because they are very small. There can be an accidental removal of the parathyroid gland, or there can be devascularization of the parathyroid gland. I've told you one thing always, that whenever you ligate, okay, whenever you ligate the inferior thyroid artery, always ligate the inferior thyroid artery close to the thyroid gland beta. Reason, if you are not going to ligate the inferior thyroid artery close to the thyroid gland, you are not only cutting the blood supply of the thyroid, you are even cutting the blood supply of parathyroid gland, right? So if you ligate the inferior thyroid artery away from the thyroid gland, you cut the blood supply of both the thyroid as well as the parathyroid gland. And due to this accidental removal or due to this devascularization of parathyroid gland, we know there is going to be decreased secretion of parathyroid hormone in the patient, or there will be a hypoparathyroidism, right? There will be a decreased secretion of parathyroid hormone in the patient's body, or there will be a hypoparathyroidism beta, or you can also call it as a parathyroid insufficiency. Hypoparathyroidism or parathyroid insufficiency will be seen. And we know whenever there is decreased parathyroid hormone in the body, obviously there is going to be decreased serum calcium in the body. And as there is going to be decreased serum calcium in the body beta, the patient is going to have signs and symptoms of hypocalcemia. That is, the patient will have perioral paresthesias, numbness and tingling. Along with that, paresthesias, numbness or tingling in the tip of fingers, and the classical clinical signs, Trousseau or Chvostek sign, right? So we know the classical diagnosis is going to be option C, that is parathyroid insufficiency. So as there is parathyroid insufficiency or hypoparathyroidism, the patient will have hypocalcemia like features. Now treatment should be what? We know beta, one thing is, if there is a mild hypocalcemia, you can just give oral calcium and vitamin D supplements. If there is a mild hypocalcemia, you have to just give oral calcium and vitamin D supplementation beta. After total thyroidectomy, any which ways, you are going to start the levothyroxine supplements. So along with levothyroxine, also start the calcium and vitamin D supplements beta. Apart from that, if there is a severe hypocalcemia, then we have to give IV calcium gluconate. If there is a severe hypocalcemia, we know we have to give IV calcium gluconate. But if the patient's calcium levels are not maintained, in most of the patients, what happens? After few months or few years of surgery beta, the calcium levels normalize, and definitely you don't need to give any calcium supplements beta. But in few patients, the calcium levels will not normalize, and in them, you may have to go for a parathyroid gland implantation. Okay, in few patients, when the calcium levels are not normalizing, even after many months of surgery, then you have to place parathyroid gland implants. PYQ in the FMG exam. Most common muscle where you have to place the parathyroid gland implant. Let me know in the chat box. Most common muscle for parathyroid gland implant placement is. Let me know in the chat box. most common muscle for the parathyroid gland implant placement is. There are very less number of questions, but we are not taking break now. Continuity mein we are going to end this. Let me know in the chat box which is the most common muscle. We know, see, if the patient is having hypothyroidism, yes, patient will definitely develop hypothyroidism after total thyroidectomy. As you are removing the thyroid gland, patient will have hypothyroidism. But these are not the signs and symptoms of hypothyroidism. In hypothyroidism, the patient will come to you with fatigue, generalized weakness, weight gain, cold intolerance, constipation, confusion, decreased attention span. These will be the symptoms of hypothyroidism. None of the symptoms have been mentioned. Clear? Hypercalcemia, no. These are not the signs and symptoms of hypercalcemia, beta. It is signs and symptoms of hypocalcemia. Bilateral recurrent laryngeal nerve injury. We know if there is a bilateral RLN injury, then both the vocal cords are paralyzed and both the vocal cords will get closed, causing a bilateral abductor palsy, as I've told you always. And the patient will have severe respiratory distress along with stridor. Right? It is the brachioradialis muscle. Do remember the most common muscle that we prefer for placement of the parathyroid gland implants, beta. It is the classical brachioradialis muscle. This has been the PYQ in the FMG exam. Be aware of that. Very good. So it is going to be the nothing else but the brachioradialis muscle, beta, which is present in the forearm. The brachioradialis muscle in forearm is the best site. Clear? So that has to be kept in mind. If they ask you what is the most common nerve injury, another PYQ, which is the most common nerve injury after thyroidectomy surgery, let me know in the chat box. Which is the most common nerve injury after the thyroidectomy surgery? Let me know in the chat box. So options are ELN, ILN, SLN, RLN. Most common nerve injured after thyroidectomy surgery options are ELN, ILN, SLN, RLN. Anybody? Bolo? Important from ENT as well. Important even from anatomy as well. Very good. So it is going to be nothing else but ELN beta. That is the most common nerve injury that is seen. Very good. So it is going to be the most common nerve injury that we see after a case of thyroidectomy surgery. So during thyroidectomy, the most common nerve injury that you see, it is ELN, that is external laryngeal nerve, also called as the external branch of superior laryngeal nerve. But from ELN and SLN, I will choose ELN as the better answer, beta, because ELN is more specific answer. Okay, it is not the complete SLN that is damaged, it is ELN which is more specifically damaged, followed by that RLN, that is recurrent laryngeal. Clear? So that is what is important to be remembered. So external laryngeal nerve followed by recurrent laryngeal nerve. RLN is not the most common nerve injured after total thyroidectomy nowadays. It has been updated way long. Clear? So that is ELN followed by RLN nowadays. And do remember the signs and symptoms. If there is an external laryngeal nerve injury, we know if external laryngeal nerve is damaged, patient will have paralysis of the cricothyroid muscle. And we know cricothyroid is the main tensor muscle. As the cricothyroid muscle gets paralyzed, the tension in the vocal cords is lost and the vocal cords become loose or bowed down. And as the vocal cords become loose, beta, the patient will have poor quality of voice. Recent question in the FMG exam, Jan May. We know after thyroidectomy surgery, a singer comes to you and she is having poor quality of voice or she is not able to sing at a higher pitch. So we know whenever a female will have poor quality of voice or she is not able to sing at a higher pitch, that means she is going to have an external laryngeal nerve injury, beta. That is important. Whereas if they say RLN injury, then do remember if there is a recurrent laryngeal nerve injury, if it is going to be a unilateral recurrent laryngeal nerve injury, then the patient is going to complain of hoarseness of voice or dysphonia. If there is a unilateral recurrent laryngeal nerve injury, patient will have hoarseness of voice or dysphonia, beta. That is going to be seen. But if there is a bilateral recurrent laryngeal nerve injury, we have discussed that whenever there is a bilateral recurrent laryngeal nerve injury, both the vocal cords are paralyzed and both the vocal cords will get closed. Reason? If there is a bilateral recurrent laryngeal nerve injury, all the nerves are paralyzed. If there is a bilateral recurrent laryngeal nerve injury, all the muscles are paralyzed except cricothyroid. And as cricothyroid is the only working muscle, being a adductor muscle, it will cause adduction or closure of vocal cord. And as the vocal cords are closed, the patient will experience post-operative respiratory distress along with stridor. The patient is going to have post-op respiratory distress, beta, along with stridor. Okay? So the patient is going to have post-op respiratory distress along with stridor. Hopefully clear to all of you now. So that is what is important to be remembered. Okay, done. These are the two questions that can come as a complication of thyroid surgery. Do remember them. Question number 13. We are having a question which says, easy hai, 60-year-old male beta presents to you. The 60-year-old male presents to the emergency with complaints of bleeding per rectum and a discomfort while defecation. On DRE or on digital rectal examination, a mass was felt inside the anal canal and further investigation revealed it is a case of squamous cell carcinoma. Which among the following is the preferred treatment in this scenario? So they have directly given the diagnosis. They said that the patient had bleeding per rectum, especially while defecation beta. Clear? While he was passing the stools. They have done a DRE and on DRE a mass was felt in the anal canal. It was confirmed that it is a case of squamous cell carcinoma. So we know the provisional diagnosis of this case is nothing else but anal cancer. Barabar? So we know beta, it is a classical diagnosis of nothing else but anal cancer. No break now. We will directly end the session. It is a short session. So why we have to take a break? Chota sa session hai. Few questions are left. That is a classical diagnosis of anal cancer, and we know anal cancer is commonly a squamous cell carcinoma, right? We know majority cases of anal cancer are squamous cell carcinoma because the normal lining of anal canal is squamous epithelium, right? We know 3 sites in GIT will have squamous cell carcinoma commonly. 1, oral cavity. 2nd, esophagus. 3rd, anal canal. So oral cavity, esophagus and anal canal has squamous cell carcinoma. Rest everywhere adenocarcinoma is seen in the GI tract. So here they are asking you what is the treatment. Bolo. We know biopsy has been done and it is confirmed that it is a case of anal cancer or squamous cell carcinoma. Treatment of anal cancer I am asking straightforward. Bolo. What should be answer? Think about it and please tell me again. We know that the anal cancer which is there beta, it is treated by an option A, that is nothing else but chemoradiation. Concurrent chemoradiation has to be given and that chemoradiation is classically known as Negro's regime. So answer to this question is option A, that is chemoradiation, which is given according to the Negro's regime beta. Reason we know, in cases of anal cancer, if you tend to go for a surgery, the anal sphincters will get permanently damaged. And if the anal sphincters will get permanently damaged beta, the anal canal will always remain open. And there will be a continuous leakage of stools. That is, anal incontinence or fecal incontinence is going to develop. That's the reason we always go for chemoradiation as the answer. Yes, if chemoradiation fails, then you may go for a surgical excision, also called as abdominoperineal resection. In case if chemoradiation fails, then only we go for a surgical excision or a abdominoperineal resection, but not always. So abdominoperineal resection is not done always. Okay, that's the reason I'm not saying option C is the best answer. Clear? Surgical excision, it is not done. It is primary management is chemoradiation because we try to save the anal sphincters. Option C says neoadjuvant chemoradiation followed by surgical excision. Surgical excision can be done, but only if chemoradiation alone fails to treat the patient, not always. So therefore, option C is not going to be yes. Okay, then the option C is going to be the answer. Option D says surgical excision followed by adjuvant chemoradiation. No, that is also wrong. So it is very clear. Next, question number 14, you are able to see beta. And in question 14, we are having a young diabetic male who has been brought to us with complaints of severe pain along with low-grade fever along with foul smell beta. And the below given finding is there. This is the given finding. This was our patient only who was homeless and he was brought to us in the emergency. What shall be the next best step beta in the management of this patient? Okay. What is the classical diagnosis? Young diabetic patient or young diabetic male having some infection near the scrotum, okay, which is polymicrobial. Multiple bacteria are responsible for this infection. Okay. Severe pain is there, low grade fever and excessive foul smell is there beta. And even you can see maggots, right? There are even maggots which are seen in the wound. Okay, because the wound was not properly treated, so maggots were there. Yes, it is a classical diagnosis of Fournier's gangrene. Very good. So it is a classical diagnosis of Fournier's gangrene. One of the commonest question asked in FMG exam from scrotum, it is Fournier's gangrene. If I talk about Fournier's gangrene, we know it is a case of necrotizing fasciite. Fournier's gangrene is nothing else but a type of necrotizing fasciitis of the scrotum. Okay, it is a Fournier's gangrene is nothing else but necrotizing fasciitis of the scrotum. We know such kind of necrotizing fasciitis can also be seen beta in the abdominal wall. Such kind of necrotizing fasciitis is also seen in the patient's abdominal wall. And when necrotizing fasciitis is seen in the abdominal wall, we classically call it as which gangrene? Let me know in the chat box. PYQ in the NEET PG examination was this. They've asked you what is going to be the name of necrotizing fasciitis seen in the abdominal wall. Anybody? Necrotizing fasciitis seen in the abdominal wall. I hope all of you are quite aware. It is known as Melanese gangrene. We have discussed this in class. Right? It is classically known as nothing else but Melanese gangrene, beta. Has to be remembered. Clear? And we know whether it is Fournier's gangrene or it is Melanese gangrene, which are necrotizing fasciitis, beta, it is nothing else but a polymicrobial infection. That is not one, but rather multiple bacteria together are known to cause this kind of infection, beta. Has to be remembered. And therefore, a lot of times, the patient might come to you in sepsis or even septic shock, right? The patient of Fournier's gangrene might come to you with complaints like pain, fever, foul smell, and the patient might be in sepsis or septic shock also. Okay? So that is what is very classical. Now they are asking you in this condition that what has to be the next best step? What is going to be the next best step, beta, in the management of this patient? This was a recent question. They are asking you next best step and not the final step, beta. So please be aware and then think about it. We know a patient of Fournier's gangrene or necrotizing fasciitis can be hemodynamically unstable or can be suffering from sepsis or septic shock. That's the reason we all have discussed earlier also. I've told you that in these kind of conditions, the first line treatment should always be basic resuscitation, beta. You have to make sure that the patient is stable. Okay, you have to go for basic resuscitation. That is A, B, C has to be done, where we have to give hyperbaric oxygen therapy. Okay, hyperbaric oxygen is considered as the first step. Apart from that hyperbaric oxygen therapy, beta, we know we can even go for nothing else but IV fluids because the patient might be hemodynamically unstable. And we all know, as it is a case of septic shock, along with IV fluids, we have to give IV antibiotics also. Because one thing I've always told you, that if it is a case of septic shock, not only IV fluids has to be given, but even along with IV fluids, you have to give IV antibiotics. Because if you only give IV fluids in a patient of septic shock, the patient's BP will never improve because the vessels are very leaky, the fluid will leak out. Clear? So IV fluids ke saath IV antibiotics to stop the inflammation or to stop the leakiness of the vessels has to be given. Clear? That is what is important. So now the best answer, yes, it has to be option D, that is hyperbaric oxygen with IV fluids. All of you are right because they have only asked the next best step. Okay, then once we have given hyperbaric oxygen with IV fluids, then we can definitely go for debridement, beta. Right? We all know that the definitive treatment in cases of Fournier's gangrene or in Melanese gangrene is debridement, removal of all the dead necrotic tissue. And one thing you have to remember, that orchidectomy or removal of testis is never required because necrotizing fasciitis or Fournier's gangrene is a superficial infection. Usually we don't need a removal of testis or an orchidectomy, but only debridement is enough. Option A is not true because hyperbaric oxygen is not there, beta, and debridement is not the next step. It is basically the final step in management. Okay, if option D was not there, then I might have marked option A as the answer. Clear? Next, option B says debridement with orchidectomy. Debridement with orchidectomy first. Orchidectomy is not required in most of the cases of Fournier's gangrene. Only debridement is done. And that is also the final step, not the next best step. CBC and swab for culture. Do remember, CBC, you can send a sample for CBC and everything. But first step is to stabilize the patient, beta. Or first step is to give hyperbaric oxygen therapy basically in the patient. That actually helps in the wound healing of the patient. There is a much faster wound healing when you have to give a hyperbaric oxygen therapy. Okay, testis is usually not affected in majority cases. Clear? Next important, this is the vac dressing that you can apply as well at times, beta. Okay, this is the vac dressing or the vacuum assisted dressing that we apply in few cases. And that can actually help in a faster and a better wound healing. In case if the wound is non-healing in nature, then we have to apply vac dressing, and I hope all of you are quite aware. The pressure of vac dressing is minus 125 millimeters of mercury. Recent question in the NEET PG examination. Minus 125 millimeters of mercury is the pressure of the vac dressing or the vacuum assisted dressing, has to be remembered. Clear? Sure. Next important, if I talk about, is question number 15, beta. Here you can see we are having a 35-year-old male who came to the OPD with complaints of swelling in the left scrotal region along with pain. Pain increases on standing and usually in the evening time beta. On palpation, it feels like a bag of worm. Very, very classical. What is the most likely diagnosis? This has been a PYQ and FMG examination, which is very, very easy. We all know. I hope all of you are quite aware about this. Yes, very good. So we know a patient who is having pain and swelling in the scrotum beta, and the pain usually increases on standing and in the evening time. Okay, and it gives a bag of worm feel. That bag of worm feel itself is the diagnostic feature, that it is nothing else but a case of option D, varicocele. What is varicocele? Whenever there is pooling up of blood in the testicular veins, and this pampiniform plexus of testicular veins, when it gets dilated and becomes tortuous, this dilated and tortuous testicular vessels is known as varicocele. So here you can see, we know that varicocele is always more commonly seen on the left side beta. If they ask you why varicocele is more common on the left side, so I have always told you one thing, that the left testicular vein does not directly drain into the IVC. The left sorry. The left testicular vein does not directly drain into the IVC. The left testicular vein beta drains into the left renal vein. And the left testicular vein drains into the left renal vein almost at a right angle. And a lot of times beta, that the testicular vein is not able to drain into the left renal vein, because left renal vein has a horizontal flow that provides a lot of resistance, due to which the left testicular vein is not able to drain properly, especially when the patient is going to have prolonged standing. Okay, especially when the patient is going to have prolonged standing or a pendulous scrotum. Okay, the prolonged standing, hanging, or a pendulous scrotum, these are the risk factors. Due to prolonged standing or pendulous scrotum beta, the left testicular vein is not able to drain properly, especially when the testis or the scrotum is not having proper support. Okay, at that time the hanging scrotum cannot drain properly and all the blood pools up in the pampiniform plexus of testicular veins, and you can compare that these left-sided pampiniform plexus of testicular veins beta, they have got too much dilated, and as they have got too much dilated and have become tortuous, that's the reason there is varicosities formed. And when varicosities form in the pampiniform plexus of testicular veins, or varicosities form in the scrotum, we call it as varicocele. We know investigation of choice in patients of varicocele has to be a color Doppler or the duplex scan. So we all know the color Doppler or the duplex scan is considered as the investigation of choice in patients of varicocele to see this dilated pampiniform plexus of testicular veins beta. Apart from that, in this condition, the treatment that we have to go for, if it is a very first time of the patient beta, if it is the first time or if it is a very mild condition, then you can go for procedures like angioembolization. Okay, you can go for an angioembolization. Another option can be a sclerotherapy. Okay, angioembolization or sclerotherapy are the minimally invasive techniques beta, which are basically used to treat a case of varicocele. But in case of angioembolization or sclerotherapy does not help, then the next option that we have is basically going for nothing else but a surgical ligation. You can do a surgical ligation of these vessels which are having pooling up of blood. And if that also does not help, then the last option and the best option is basically considered as a varicocelectomy. Then the last or the best option that we have is basically a varicocelectomy beta, excision of the extremely dilated and tortuous varicose veins beta, varicose veins beta is known as varicocelectomy. Hopefully clear. Here you can see this is the classical case of a varicocele where the vessels are dilated, and when you palpate or when you try to feel the scrotum, you will feel that bag of worm like feel beta. Clear? Okay, hopefully clear to all of you now. So that is what is important to be remembered. No issues with this. Now, if I talk about the differences beta, one is nothing else but epididymal cyst and second is spermatocele. Do you remember the basic difference? Epididymal cyst, which is there, it is congenital. That means it is going to be present since birth beta. And this epididymal cyst or that swelling which is there, it is found behind the body of testis. So behind the body of testis, you can find an epididymal cyst. We know this epididymal cyst is actually a multiloculated cyst beta. There are multiple small collections of fluid. And as that it is a multiloculated cyst, when you try to feel the scrotum, you usually get a bunch of grape-like appearance. The bag of worm-like appearance is a feature of varicocele, but bunch of grape-like appearance, if they say, please think about a multiloculated epididymal cyst. We know it contains clear fluid, and as it contains clear fluid, it is brilliantly transilluminant beta. That is, it is brilliantly positive on the transillumination test. Okay, and do remember here excision should be avoided, especially in the young patients beta. In young patients we don't go for an excision beta. In old patients you can go for excision or the surgical removal of that epididymal cyst. Next is spermatocele. Another differential, spermatocele is nothing else but an acquired retention cyst beta. So whenever there is a retention of the seminal fluid or retention of the testicular fluid beta, that basically leads to formation of spermatocele. It is an acquired retention cyst. It is present behind and above the testis. It is a uniloculated or a unilocular cyst. There is a single collection of fluid which is seen, and as it is a uniloculated cyst, it basically looks like a third testis. So if they are saying on palpation you are able to palpate a third testis, basically that could be a diagnosis of a spermatocele beta, has to be remembered. It will contain barley water like fluid, and as it contains barley water like fluid, it is going to be transilluminant, or it is going to be positive on the transillumination test, but it is not going to be brilliantly positive. It is positive but not brilliantly positive. And most important keyword, this collection which is there, it will not only have some fluid, but it will mainly have sperms inside it. If sperms is found, basically we call it as a spermatocele, and the treatment in cases of spermatocele can be a surgical excision. So surgical excision can be done in the treatment of spermatocele beta. Clear? For 10-15 more minutes, because now the questions are easy somewhat. Okay? Next question is very easy beta. That says, question number 16 says, which among the following is used for grading of prostate cancer? Another PYQ one liner. Grading of prostate cancer is going to be done by which among the following scoring system? This was a PYQ, so let me know in the chat box. Very easy. Just telling you the names of various scores. Yes. Do you remember here, if I talk about basically the grading of prostate cancer, I hope all of you are quite aware. Answer has to be option A, that is the Gleason score beta. Gleason score can tell me about the grading as well as the prognosis in patients of prostate cancer. You don't have to go into the too many details of how the Gleason scoring system is done, but at least remember that the grading and prognosis of the prostate cancer is usually decided by the Gleason score. That was a previous year one-liner question, has to be remembered. Bethesda scoring system is basically the cytopathological grading beta, okay, or the FNSC grading for which organ? Anybody let me know in the chat box. So Bethesda scoring system is basically the cytopathological grading or the FNSC grading for which organ? Let me know in the chat box. So do remember, cytopathological grading or the FNSC grading of thyroid which is there beta, it is basically called as the Bethesda classification. We know in cases of thyroid swellings, initially we have to go for a ultrasound, and when you do an ultrasound you get a thyroid score, and after the thyroid score beta, if the thyroid score is high, like if the thyroid score is 3, 4 or 5, thyroid 3, thyroid 4 or thyroid 5, which is suspicious of a malignancy, we have to send our patient for FNSC. And when we do an FNSC beta, then at that time you get the FNSC grading or the cytopathological grading of thyroid gland. That is the Bethesda score or the Bethesda classification. Next is Nottingham score beta. Do you remember Nottingham score is the prognostic score for which cancer? Anybody? So we know based on the histopath finding or based on the biopsy finding beta, if you're going to tell the prognosis, or if the pathologist is going to tell the prognosis, whether it will be good or bad, that is known as Nottingham score. So that Nottingham score is actually a prognostic index used for breast cancer. So do remember, in cases of breast cancer, the prognostic index that we use is basically called as Nottingham index or the Nottingham Nottingham prognostic score. Okay? So for a case of breast cancer, whenever we look at the histopath and tell the prognosis, that is basically called as the Nottingham score or the Nottingham index. Next important, if I talk about, is the Ranson score. I hope all of you are quite aware. Ranson score is going to be the clinical severity score used in patients of which condition? That is based on the clinical findings as well as the lab findings of the patient. If you are going to tell the severity of the disease, that is what is known as the Ranson score. The Ranson score is the clinical severity score for acute pancreatitis beta. So do remember, for a case of an acute pancreatitis, okay? Okay, so do remember, it is a case of acute pancreatitis. See beta, we have to be true to our work. ultimately people are going to recognize it at some or the other point of time. So those people who are basically in need, they are still watching, they are still there. Clear? So we are trying our best, and hopefully just this session just helps to everyone it reaches out to. That is the only aim behind these sessions, nothing else. Yeah. So clinical severity score for acute pancreatitis is the Ranson score beta. Do you remember two more scores that I would like you to remember? One is Balthazar grade. I hope all of you are quite aware that Balthazar grade which is there, it is nothing else but the CT severity index or the CT severity score for acute pancreatitis again. That is based on the CT scan findings beta. If you are going to decide the severity of acute pancreatitis, that is basically called as the Balthazar grade. So CT severity index for acute pancreatitis which is there, it is classically known as the Balthazar grade or the Balthazar scoring system. And the last one that I would like you to remember is nothing else but the classical sorry, Bloom-Richardson score. Just remember the name of Bloom-Richardson score. I hope all of you are quite aware that Bloom-Richardson score which is there, it is going to be again the histopathological grading system that is used for breast cancer patients. So based on the histopath findings or based on the biopsy findings, if you do the grading of breast cancer as low risk, intermediate risk and high risk, we know that histopathological grading of breast cancer is classically called as the Bloom-Richardson score. Clear about? So Bloom-Richardson score is nothing else but the histopathological grading for a case of breast cancer beta has to be remembered. Understood. And lastly, you might have discussed about two scores in medicine as well. One is the Chai-Turcotte-Puck score. We have discussed that in liver transplant. So it is the Chai-Turcotte-Puck score and the MELD score. Yaad rakhna. Chai-Turcotte-Puck score basically and the MELD score. Okay, is going to be nothing else but beta used for liver transplant. Whenever you have to decide whether your patient needs a liver transplantation or not, you either use the Chai-Turcotte-Puck score and the MELD score. Okay. Next important is question number 17. Very easy and a direct question that you can see. We are having a 30-year-old female beta who has underwent the below given procedure as shown in the image following a burn injury. Which among the following statement is true regarding the given procedure? They are asking you. First of all, what is the name of the procedure? Let me know in the chat box. What have we done? This was a recent NEET PG question. What have we done in the image? Basically, let me know. What do you think it is? Anybody? So please remember here the patient had a burn injury beta, and as the patient had the full thickness burns, we know a lot of times in full thickness burns you can see this black necrotic leathery skin, and this black necrotic leathery skin which is formed beta, it is classically referred to as an eschar, right? It is classically referred to as an eschar. It is usually seen in patients of full thickness burns like 3rd or 4th degree burns. Barabar? Now we know this eschar is actually going to cause a compression around the chest, or it can cause compression around the limbs beta, right? So we know definitely it is causing compression around the chest, which can cause respiratory distress or hypoxia in the patient, or it can cause compression around the limbs, causing compartment syndrome. The eschar can lead to two problems. One, if it is present around the chest wall, the patient might have respiratory distress beta, and if the eschar is present around the limbs, the patient might develop compartment syndrome beta. These are the problem. So therefore, what is the treatment of an eschar? This was a PYQ again. I hope all of you are quite aware that treatment of an eschar is take a surgical blade beta and make deep cuts over the eschar. Why? Because as you make deep cuts on the eschar, the pressure which is building up, it gets released. And as the pressure gets released, now the patient is not going to have any respiratory distress, or the patient is not going to have any features of compartment syndrome. Just like we do fasciotomy for compartment syndrome, here we are doing an escharotomy for an eschar beta. This is nothing else but an escharotomy for an eschar which has been done in the picture. Now they are asking you that which among the following statement is true regarding the escharotomy which has been done in the patient. So we know escharotomy has been done in the patient. Barabar? So now they are asking you which among the following statement is true. Option A says done for circumferential burns. Is it true? Yes, it is usually done for circumferential full thickness burns, because only in circumferential burns there can be a complete compression of the chest which can happen leading to respiratory distress. So it is done for circumferential burn. Option B says post burn contractures are managed by this procedure. No, post-burn contractures which are there, beta, which are seen after healing of the burns, that are usually managed by plastic surgeries like VY-plasty. I've already told you. VY-plasty is used for the post-burn contractures, not an sclerotomy. Option C says it helps with impaired wound healing. No. Impaired wound healing hai, so you can definitely go for a regular debridement and you can go for a vacuum assisted dressing. So regular debridement, vacuum assisted dressing, antibiotic prophylaxis, these could be definitely the things that may help in a delayed wound healing or an impaired wound healing, not an sclerotomy, right? That is important. Clear? Next important option D says done routinely before skin grafting in full thickness burns, beta. No, it is not done routinely before skin grafting. Why you need routinely? Only if eschar is only if eschar is present and it is causing compression, then only you have to go for a escharotomy. Why we have to do it routinely, right? So the answer to that question is nothing else but option A. Yes, it is definitely done only for a circumferential burn, beta, has to be remembered. Clear? Yes, achalasia is pending. Now let's talk about the next question. Hopefully eschar and escharotomy is clear to all of you. Now a question that a lot of people are sending me, they are confused about. I was not actually going to cater this question because this is very rare to appear in the FMG examination. But still I thought as it is giving you anxiety, let me address this question easily. So a patient presents to the OPD with complaints of dysphagia, beta, and that dysphagia is more to liquids as compared to solids. We all know dysphagia more to liquids compared to solids is definitely a diagnosis of an achalasia, beta. And the patient undergoes an esophageal manometry. We all know achalasia mein the lower esophageal sphincter is not able to relax, or the lower esophageal sphincter is in a contracted state, beta. And that's the reason the lower esophageal sphincter pressure is very high. And to measure that pressure, the investigation of choice has to be an esophageal manometry, beta. Clear? When esophageal manometry was done, findings reveal that there is an absent peristalsis in the body. So I've told you that in in cases of achalasia cardia, you can see aperistalsis or ineffective peristalsis. You can see there is absent peristalsis in the esophageal body, and they have said there is a hypertensive LES or a hypertensive lower esophageal sphincter, beta, with esophageal pressure of more than 450 millimeters of mercury. So throughout the esophagus, the pressure is exceeding more than 450 mm of mercury, beta. And there are spasms throughout the esophagus. The most important keyword of the question. There are spasms inside the esophagus. It is a spasmodic achalasia cardia, beta. That is what is very classical. They are asking you what is your most probable diagnosis. Now we know it is achalasia cardia because dysphagia more to liquids, manometry pe absent peristalsis or hypertensive LES and a high esophageal pressure has to be a diagnosis of achalasia, beta. But now which type of achalasia, that we have to see. Okay. Now if I talk about, do remember there are three types of achalasia. Very simple, man. I'm telling you the keywords. If it is a type 1 or the classic achalasia, beta, the patient is going to have a impaired esophagogastric junction relaxation or impaired relaxation of the lower esophageal sphincter, and the patient is having an absent peristalsis or aperistalsis, but there is no significant esophageal pressurization. That means the esophageal pressure is not very high, beta. Okay, it is not very significant. Next is type 2. Type 2 achalasia cardia is going to be associated with compression. Here again, the patient will have an impaired esophagogastric junction relaxation. That means definitely, beta, the lower esophageal sphincter is not able to relax. Okay. Next, the patient will have an absent peristalsis. Apart from that, do remember there are pan-esophageal pressurization is more than 30 millimeters of mercury. That means throughout the esophagus, the pressure is high and it is exceeding more than 30 millimeters of mercury, beta. Clear? Next important, if I talk about it, type 3 achalasia, also called as a spastic achalasia, beta. Type 3 achalasia or the spastic achalasia which is seen in this keyword is spasms itself. Clear? There is an impaired esophagogastric junction relaxation or the lower esophageal sphincter is not able to relax. Apart from that, there is an absent peristalsis again. But the keyword is, do remember, the patient is actually going to have spasms. Okay. So there are going to be spasms throughout the esophageal wall, beta. That is what is the keyword of the question. So these are actually going to be the keywords of the question, beta. Okay? That has to be remembered. So the first one is nothing else but a classic achalasia. In classic achalasia, beta, there is no spasms and there is no pan-esophageal pressurization. In type 2, the patient is having a high pan-esophageal pressurization. And in type 3, there is a pan-esophageal pressurization also associated with spasms. So here, They have said there is a absent peristalsis which can be seen in all types of achalasia. Second, they have said hypertensive ileus can be seen in all types of achalasia. Next, they have said pan-esophageal pressurization of more than 450 millimeters of mercury can be seen in type 2 as well as type 3 achalasia. But the most important keyword are spasms. As soon as this is spasms, we know the diagnosis has to be type 3 achalasia beta or the spastic achalasia. Type 2 hota to spasms would not have been seen beta in this condition. Clear? So that is what is important. Clear? No issues with this? Thank you so much, beta. Okay, congratulations. Do you remember nutcracker esophagus is the one where the lower esophageal sphincter pressure which is there, beta, it is usually in the range of 180 to 200 millimeters of mercury. So the esophageal pressure is usually in the range of 180 to 200 millimeters of mercury in cases of nutcracker esophagus. That has to be remembered. And again, nutcracker esophagus is not going to be associated usually with spasms throughout the esophagus. Nutcracker esophagus is not associated with spasmodic esophagus, but it has to be remembered. Jackhammer esophagus is again a condition which is a motility disorder of esophagus, but again, the pressures are going to be different and spasms are not going to be seen. So option A and option D are very rare conditions. So you have to mainly remember about achalasia or diffuse esophageal spasm. And we know in patients of achalasia cardia, as the patient has dysphagia, we do a barium swallow. And when we do the barium swallow, we are able to see a smooth tapering. And that smooth tapering is classically known as the bird beak appearance, also called as the pencil tip sign. If bird beak appearance, pencil tip sign or smooth tapering is an option, then that will be my best answer. If it is not an option, then you can mark it as rat tail sign also. Okay? And we know investigation of choice will be a esophageal manometry. And when we do a esophageal manometry beta in patients of achalasia, we know the patient's pressure usually in classic achalasia cardia is going to be between 26 to 100 millimeters of mercury. Normally the pressure should be between 8 to 25 millimeters of mercury, but in classic achalasia cardia, the lower esophageal sphincter increases and the lower esophageal sphincter pressure increases, and it is usually in the range of 26 to 100 millimeters of mercury beta. And the treatment of choice in patients of achalasia cardia, we all know that calcium channel blockers or endoscopic dilatation or botulinum toxin injection or POEM surgery can be done. But if they ask you what is the best treatment or the treatment of choice for achalasia, so do remember the treatment of choice for achalasia cardia is nothing else but a Heller's myotomy surgery beta. The Heller's myotomy surgery helps in relaxation of the lower esophageal sphincter and the food can easily pass through the lower esophageal sphincter. Clear? Next important is nothing else but question number 19 integrated with path. We are having a 35-year-old female patient who presents to us with seizure episodes beta. Radiological investigation reveals there is presence of frontal lobe mass with a foci of calcification. Excisional biopsy shows there is presence of sheets of cells with fried egg appearance beta, and the patient has been diagnosed with a grade 2 glioma. And they have said that the patient has been started on chemotherapy and the patient is showing good response to chemotherapy as well. Which among the following tumor best describes this, or which among the following tumor suits the description given below? So I hope all of you are quite aware now. It is very classical. They have said clearly that the patient is diagnosed with a grade 2 glioma. So that means patient is having a glioma or a brain tumor due to which the patient was having seizure episodes. And they have clearly mentioned there was a frontal lobe mass with a foci of calcification. So we know this is a glioma which is calcified. See, there are there are three intracranial tumors which are calcified beta. First is meningioma, second is oligodendroglioma, third is craniopharyngioma. Meningioma, oligodendroglioma and craniopharyngioma. These are the three common intracranial tumors which are calcified. And they have clearly said that there are sheets of cells along with fried egg appearance beta which is seen. And we all know that sheets of cells with fried egg appearance is a very, very classical feature of nothing else but option C, that is your oligodendroglioma. Right? Yes, all of you are right. It is a classical diagnosis of oligodendroglioma. Meningioma is also a intracranial tumor, but it is not a frontal lobe mass beta. It does not arise from the brain. It arises from the meninges beta. Clear? So they would have said a mass is present inside the cranial cavity arising from the dura mater, or a dural mass is present. That is how the question of meningioma comes. And fried egg cells are never seen in meningioma. We know that meningioma is going to show us the calcified lamellated bodies called as psammoma bodies beta. Clear? Whereas glioblastoma multiforme is not a grade 2 glioma beta. Glioblastoma multiforme is a grade 4 glioma. it is going to have the worst prognosis among all the types of brain malignancies that we have. Okay, the most common primary brain malignancy in adults is glioblastoma multiforme. The most common primary brain malignancy in children is medulloblastoma. Okay, most common brain malignancy metastasis, mainly from small cell cancer of lung. Most common primary brain malignancy in adults, glioblastoma multiforme, that is grade 4 glioma. Most common primary brain malignancy in children, medulloblastoma beta. Hopefully clear. That has to be remembered. And we know glioblastoma multiforme is going to be a butterfly shaped tumor, and it is actually going to be characterized by the pseudo-palisading or the serpentine necrosis on histopath, not by any Friedech cells. And craniopharyngioma is more commonly seen in children, not in adults. It is a suprasellar tumor which is present near the pituitary fossa beta. And as it is a suprasellar tumor arising from the Rathke's pouch, it can compress the optic chiasma beta, leading to bitemporal hemianopia. Yes, it is a calcified brain tumor, but it is basically going to cause an bitemporal hemianopia due to optic chiasma compression, commonly seen in children. And most important beta, that in craniopharyngioma, histopath shows you the wet keratin-like appearance. Okay, wet keratin or mortar oil-like appearance is seen. Clear? Here you can see this classical picture. These are nothing else but the Friedech cells beta. Okay, you can see there is a cell with a central nuclei and a perinuclear halo. The cells with central nuclei and perinuclear halo are classically called as the Friedech cells. Okay, along with these Friedech cells, you can see one more feature, and these are like the net-like capillaries, and these net-like capillaries are known as chicken wire capillaries. So apart from the Friedech cells, you are able to see the classical chicken wire capillaries. So whenever you see the classical Friedech cells on histopath along with the chicken wire capillaries, and they ask you which kind of brain tumor it is, always answer it as a case of an oligodendroglioma. Always answer it as a case of an oligodendroglioma beta. Hopefully clear to all of you now. So that is what is important to be remembered. Whereas if I talk about the next one, here you can see these are the classical calcified lamellated bodies, and we know these calcified lamellated bodies on histopath are classically known as Samoma bodies. The classical calcified lamellated bodies on histopath are known as the Samoma bodies, which are an example of dystrophic calcification. And these Samoma bodies, which are dystrophic calcification, they are going to be seen in a intracranial tumor, not in a brain tumor, but an intracranial tumor called as a meningioma. And if I talk about a meningioma, we all know in meningiomas, when I do a CT or MRI, it shows us the classical sign called as the dural tail sign. You can see a calcified mass arising from the dura mater, that is classically known as the dural tail sign. So CT or MRI showing a dural tail sign and the histopath showing the Samoma bodies. Always think about meningioma, which is a very commonly repeated question, twice or thrice repeated question in FMJ exam. They say patient has a long history of headache along with seizures. MRI or CT was done, on which you are able to see a calcified tumor beta or a calcific mass which is arising from dura mater. Okay? Or they might say the dural tail sign, or they might give you MRI picture also. And they might say that after removal of the tumor, you are able to see this kind of histopath finding, that is Samoma bodies. What is the likely diagnosis? Think about meningioma. Next important, this is the classical picture where malignant cells are arranged in the periphery and there is necrosis in the center. Okay, this is not cytoplasm, this is necrosis. Whenever the malignant cells are arranged in the periphery beta and there is necrosis in the center, we know it is classically called as pseudo-palisading. Apart from that, the necrosis that you are able to see in this, that is the classical serpentine necrosis, also called as the garland necrosis. So you can see pseudo-palisading. Along with that, you are able to see the classical serpentine necrosis, also called as the garland necrosis beta. So we know it is a classical diagnosis of nothing else but a case of glioblastoma multiforme. And we all know that glioblastoma multiforme is a grade 4 glioma, as I've told you. It is actually associated with the worst prognosis. Among all the brain malignancies, the worst prognosis is associated with GBM or glioblastoma multiforme. And when you do a CT or MRI, you are able to see a classical butterfly shaped tumor. This tumor grows in both the cerebral hemispheres, and that's the reason you can see a classical butterfly shaped tumor on the CT or the MRI beta. That is a classical feature of GBM or glioblastoma multiforme. And the last tumor that you have to remember from the brain is basically this. This is nothing else but a schwannoma beta. I hope all of you are quite aware that schwannoma is going to be a tumor that usually arises from the Schwann cells or from the nerves beta, like the vestibular schwannoma or the acoustic neuroma, which is a benign tumor arising from the 8th cranial nerve or vestibulocochlear nerve. Here you can see definitely there are going to be areas which are hypercellular and hypocellular. The hyper and hypercellular, sorry, the hypercellular and the hypocellular areas are known as antennae A and the antennae B areas. Apart from the antennae A and the antennae B areas, beta, you can see the classical verrucate bodies, right? The acellular areas, the classical verrucate bodies are going to be seen. Clear? So that is the feature of nothing else but, yes, it can be seen pseudopalisading in BCC beta. But here definitely that pseudopalisading along with the serpentine necrosis is seen. That is a feature of GBM. Okay? Do remember fried egg cells which is there. It is a feature of multiple tumors or multiple malignancies. Fried egg cells can be seen in oligodendroglioma. It can be seen in hairy cell leukemia. It can be seen in seminoma and dysgerminoma. So at least remember the four important ones: oligodendroglioma, hairy cell leukemia, seminoma and dysgerminoma are the ones which are going to have the classical fried egg cells beta. Clear? That is important. Surgical excision or neurosurgery is the treatment for most of the brain tumors beta. Okay. Only if there is a metastasis, then we go for a chemoradiation that is going to be done. But otherwise, it is mostly a surgical excision that has to be done. Okay. That is what is important. And you can definitely give a neoadjuvant or adjuvant chemotherapy depending on the patient's condition. Okay. If you want to go in depth, that is different then. But this is the basic idea you should have. Next, question number 20, beta, we are having a 3-day-old infant who presents to us with complaints of breathlessness shortly after birth. Physical examination reveals there are diminished breath sounds on the left side and there is a scooped out abdomen or a classical scaphoid abdomen that you can see. A chest x-ray has been given below. Based on the clinical scenario, they are asking you what is the most appropriate management of the patient. So I hope all of you are quite aware. What is the classical diagnosis of this case? Please tell me. What is the classical diagnosis of this case, anybody? So we know that a 3-day-old infant brought to us with complaints of breathlessness or respiratory distress along with diminished breath sounds on the left side because the left-sided lung might be collapsed and scooped out abdomen or scaphoid abdomen classically. And the chest x-ray given which shows a very classical appearance, that is, here you can see on the left side you are able to see bowel loops in the thorax. Normally I should see definitely the completely black lung fields in the thorax beta, but here rather than seeing completely black lung field, I am able to see the bowel loops, the air filled or the gas filled bowel loops in the thorax. And we know if there are air filled or the gas filled bowel loops in the thorax, that means there is herniation of the abdominal organs in the thoracic cavity. And how did the abdominal organs herniate in the thoracic cavity? Because of a defect in the diaphragm. Okay, due to a defect in the diaphragm beta, we know that the bowel loops have herniated in the thoracic cavity. So the diagnosis is classically known as the congenital diaphragmatic hernia. The diagnosis is classically known as the congenital diaphragmatic hernia beta. I hope all of you are quite aware that the classical diagnosis of congenital diaphragmatic hernia, right? And which type of congenital diaphragmatic hernia it is? Bogdalic. Very good. Okay. So we know it is a classical diagnosis of Bogdalic hernia, the most common type. We know the most common type of congenital diaphragmatic hernia is the Bogdalic hernia beta. Okay, and we know Bogdalic hernia is going to be seen on the left side and it is posterolateral. So left-sided defect at the posterolateral part of diaphragm has to be Bogdalic hernia. Morgagni's hernia is on the right side anteromedial part. Okay, right side anteromedial defect is Morgagni, but left-sided posterolateral defect is Bogdalic. And we know here they have said that there are diminished breath sounds on the left side and you can see bowel loops in the left side of the thorax. So we know it is a Bogdalic hernia beta. As there is herniation on the left-sided lung is compressed, causing diminished breath sounds. So we know the classical diagnosis is CDH. They have asked you what is the best management to be done. So I hope most appropriate management they have asked you. Option A says an immediate surgical repair. Immediate surgical repair can be carried out beta. But first thing is basically to relieve the respiratory distress of the patient. So immediate surgical repair, a surgical repair will be carried out, not an immediate one, but yeah, we will definitely first of all try to manage the patient and then we will go for a surgical repair. Option B says observation and conservative management. No, not only observation and conservative management is actually going to repair that diaphragmatic defect or repair that hernia beta. Option C says placement of nasogastric tube for decompression. Yes, seems to be a very, very good option. Reason, if you place the nasogastric tube or the Ryle's tube beta, all the gas or all the air from the bowel is actually going to be released beta and there will be decompression of the bowel. As there will be decompression of the bowel, or the bowel will get collapsed, we know there is no compression of lung. And as there is no compression of the lung can expand basically beta, and the child is able to breathe properly. So this seems to be a very good option. Surgical repair is done, but it is not an immediate surgical repair beta. First, we have to insert the nasogastric tube or the rice tube to compress the bowel. Okay. Initiation of high volume ventilation. Even if you go for a high volume ventilation beta, and if definitely the bowel is going to be sorry, in case if you are going for high volume ventilation, and definitely beta, if the bowel is going to be distended, they are going to compress the lung, and the patient might not have a immediate improvement in the respiratory distress. So first is placement of nasogastric tube for decompression, then definitely start the ventilation. But we know that the ventilation should never be a bag and mask ventilation. Rather, bag and mask ventilation is absolutely contraindicated, that we all know beta, because if I do a bag and mask ventilation, we know the patient's condition or the respiratory distress is rather going to worsen and not improve. And apart from that, you can go for a endotracheal intubation. The airway of choice we all know in patients of congenital diaphragmatic hernia, the airway of choice is nothing else but an endotracheal intubation to be done. And then finally, you can go for a surgical repair beta. Then you can go for surgical repair, where we have to reduce all the herniated organs, and then we have to close the defect. When you are closing the diaphragmatic defect, mainly preferably use a prosthetic patch, because we know beta mesh is going to shrink. If you are going to use the mesh, what will happen? We know there will be a risk of recurrence, because as the child will grow and the mesh will shrink beta, there will be a very high risk of recurrence. So better is, for the closure of diaphragmatic defect in children of CDH, always use a prosthetic patch over a mesh beta. Prosthetic patch is going to be much better option than a mesh. Clear? So that is all from my side. Thank you so much, and it was nice to have a session. Okay, may the departed souls rest in peace. And apart from that, as just a tribute to them, I am truly grateful to Dr. Ashish and the NLC team that they have taken this initiative, so that we can actually pay tributes and help those people who are actually in need, because a lot of students were struggling and their books were not there, and a lot of them were struggling. So I'm glad that he came up and he approached us. So yeah, all the best for the examination. I know you are going to pass out with flying colors. You are definitely going to do well in the exam. Condition being, you have to just be calm and composed to face the examination. Wherever you get blocked, wherever you get too much saturated, take pauses, close your eyes, just focus on your breathing, drink some water, and again start reading the question. Don't keep on wasting your time by rereading the same question twice or thrice, just because your brain is fogging out or you're too much saturated and exhausted. Second important, please be on time. In NEET UG also, a lot of people have missed their attempts just because they were not on time. Even 1 minute late is going to be dangerous. So please be on time and on the examination hall. Carry all your essentials properly, whether it is your admit card or anything else that you are going to need on the exam day. Please carry it along with you. A lot of people have got centers which are very, very far from their home, not even in their home states, some different state. Please, please, please try to go to that exam centers a day prior itself. Get well settled, okay? And once you definitely rent the hotel or something, just stay over there, get well settled. Even for the last day, if you're not able to study, that's fine. But don't travel. Don't travel too much on the last day. Don't keep the traveling for the last day, because on the last day, if you're going to travel and you're not properly sleeping, then you might be exhausted and you might not do well in the examination. So just travel a day prior, get yourself relaxed somewhat before examination, take proper sleep. Now onwards, please don't be awake till 2 or 3 or 4 or 5 in the night. Make sure that you are sleeping or going to bed by 11 or 12 a.m. 11 p.m. or 12 p.m. so that definitely you are waking up by around 6 or 7 or 8 maximum, so that you are active by the exam time. Make sure you are solving 2 sets of questions, one in 9 to 11:30 and second in 2 to 4:30 time, so that your brain is trained in that manner that you have to solve the questions during that time frame. Don't keep on reading too many things. Make sure that you are not awake just a night prior to the examination. I always say one thing, that if you are not able to do it in 6 months, how you are going to do it in 6 hours? So don't faltu ke have that idealism. No, if I study for that last 6 hours before the examination, I'll be able to do well. No, you will just make a disaster in the examination. Better is take a proper sleep of 8 or 9 hours, I would say. If not possible, at least 4 to 5 hours. I know anxiety will be there. So at least 4 to 5 hours of sleep a day prior to the examination will actually give you a best of your performance. Clear? So make sure that is going to happen. And whatever you have studied basically, beta, okay, just make sure that you are revising things also along with it, not only watching the videos, because watching videos can just be a passive learning. You have to do extra efforts. Okay? So that is important. So make sure whatever doubts you have, you can always reach out to me at any point of time. Okay? Be calm and composed. If you are going to the examination hall before the first exam, after the first exam, in the break time, don't please discuss questions with anyone. Okay? You are not sure that whether the question was right or wrong, but in case if you start thinking that the questions you marked were wrong, you get a lot of anxiety and a nervousness, and you carry that baggage and paper too. Never discuss any kind of questions. Don't hamper your performance or others' performance also in the examination. Okay? Whatever questions are coming in front of you, do remember that that has been already served on your platter. What you have to do is get the best out of it. Don't think about the previous question, whether it was right or wrong. Don't think about the upcoming question, whether it will be right or wrong. Just think about the question that is exactly in front of you. You have to read that question. You have to read the last line twice. Understand the question. If you can translate it into your own mother tongue if the language seems too difficult. And once you have understood the question, try to make a provisional diagnosis or try to narrow down your thinking, and then start ruling out the options and then get the best answer, whatever you can. Okay? Don't try to directly get to the answer, because otherwise you will always miss out. As I've told you, there are some keywords or there are some tricks basically in the question. So if you directly read the option, what happens a lot of times is that one option gets stuck on in your head. And even if after reading the question, that same option keeps stuck in your head and you mark that answer. Okay, that is one problem. So read the question properly and then only mark the answers. Second important, a lot of people keep on changing their answers. Please don't do that. Even if you're having excess time in your hand, please don't keep on changing your answers frequently. If you change your answers frequently, maybe you're marking 2 questions right, but the 8 questions wrong. Don't do that. Just try to control your urge of changing the answers repetitively in the examination. Clear? So all the best from my side, and thank you so much.